Hello everyone. A very good morning to all of you. Am I live? Can you see me? Can you hear me? Kindly someone give me a thumbs up in the chat box if I'm clearly visible and audible to you guys. Give me a minute to confirm if I'm clearly visible audible. Okay, I guess it's working. Yes. So it's working. Okay. So a very good morning to all of you. I am Dr. Priyanka Sachdev here, and today I am here to take a new series of cardiovascular system in pathology. So cardiovascular system is one of the system in which most of the students find difficulty and many important questions come from this topic. So this topic is not only important for university exams or second prof MBBS students in pathology, but in all competitive exams, many MCQs come from cardiovascular system. So in cardiovascular system, 5 or 6 topics are most important to do that you cannot leave for your exams. So the first topic which I am going to take today is ischemic heart disease, in which I will discuss angina, angina pectoralis, and I will discuss myocardial infarction. So both I am going to discuss under this heading, that is ischemic heart disease, right? Or coronary artery disease, whatever you say. After that, the next important topic in cardiovascular system is endocarditis. So the 4 type of endocarditis which we have to take in detail: rheumatic heart disease, infective endocarditis, Libman-Sack endocarditis, and non-bacterial thrombotic endocarditis. So all those 4 endocarditis that will be taken in the next session. After the session, the next session is endocarditis. So we will be studying all 4 type of endocarditis in detail, right? And after that, the next most important topic here, ischemic heart disease, and after that, heart failure, cardiac adaptations, and myocarditis, pericarditis. We have many important topics. We will be taking all those today only one by one. So let's start serious without wasting any further time. So let me come on the topic directly. Today I am going to teach you ischemic heart disease, that is known as IHD, also known as coronary artery disease, that is known as CAD. Now, what is ischemic heart disease or what is coronary artery disease, IHD or CAD? To understand the definition of ischemic heart disease or coronary artery disease, actually it is an imbalance between the demand and supply of the heart. So you have to understand what is the demand of the heart and what is the supply of the heart, demand and supply of the myocardium. If imbalance occurs, that is ischemic heart disease or coronary artery disease. Now, what is the demand and supply? Now, in this sketch diagram, can you see a simplified diagram of heart? You all can see the 4 chambers of the heart, the right side, the left side, the 2 auricles, the 2 ventricles. You can see the blood vessels which are derived from the various chambers. You know the complete circle. I'm not saying that. Right. So you already know that. Now see, please everyone concentrate on the left ventricle. Can you see this is the left ventricle? Yes. So left side of the heart contains pure blood. We all know that. So whenever left ventricle contract, whenever left ventricle do systole, the blood comes in aorta. The pure blood, the oxygenated blood comes in aorta. And that blood is given to all the organs. That blood is given to all the organs. We know that. So whenever left ventricle is doing systole, whenever the left ventricle is contracting, pure blood, oxygenated blood is coming in aorta, and that is distributed to all body organs from head to toe. So this is the supply of the heart. This is the supply of the myocardium. Now, why left ventricle is doing systole? So in the wall of the left ventricle, cells are present. These are cardiomyocytes, the smooth muscle cells or cardiomyocyte cells or myocardial cells, whatever you say. These cells, whenever these cells, I have drawn the wall of the left ventricle, you all can see. So whenever the left ventricle is contracting, whenever these cells are contracting, the left ventricle do systole. And whenever these cells are relaxing, the left ventricle do diastole. So for contracting of these cells, these are the cells, myocardial cells. Whenever they are doing contracting, systole happens. So for contraction, these cells require ATP. They require ATP for contraction. And ATP is derived from oxygen. From oxygen, ATP is derived. And for oxygen, they also require blood. So from where? So basically, when left ventricle is contracting, blood is given to all body organs via aorta. But from where left ventricle cells get blood? That is my question to you. So for contracting, they also require blood. Heart is also a human body organ. So left ventricle, when contract, it gives blood to all body organs via aorta, right? But from where the left ventricle or the heart gets blood? So the answer is coronary. The answer is coronary. You got my point? So you can see in this diagram, I have drawn the coronary. Can you appreciate the coronary? So from the aorta, blood vessel is derived. The name of that blood vessel is coronary. Now you all can see it is derived from aorta only. So it is derived from the aorta. This is the coronary. The bigger one which I have drawn, which I have marked here, this is known as conductance vessel, and the small coronaries are derived from which this is known as resistance vessel. Resistance vessel. So one conductance vessel and multiple resistance vessels are derived, and they are supplying the wall of the left ventricle from outer to inner side. You all can see this is the coronary I have drawn with purple color, and it is derived from aorta. So the bigger coronary, the longer one, this is conductance vessel, and multiple small resistance vessels are arising from the big conductance vessel. They supply the wall of the left ventricle from outer to inner side. Now let me draw the cells in the wall of the left ventricle. This is the wall of the left ventricle containing cells. Can you see I am drawing the green color cells? These are myocardial cells or smooth muscle cells. All these cells which are present in the wall of the left ventricle, they are getting oxygenated or pure blood via coronary. So whenever these all cells, myocardial cells get oxygen from the coronary, the oxygenated blood from the coronary, they are getting blood from the coronary. Via blood, they are getting oxygen. They convert oxygen to ATP and they have ATP. Since they have ATP, they can contract. Since they can contract, they can do systole. They can do systole. Since they can contract, the systole will happen here. Here, the systole will happen. Whenever they will contract, whenever systole will happen, the blood is given to the aorta and that is distributed to all the organ. So what I have told you this story, why I have told you. So whenever coronary is giving blood to the left ventricle cells, the left ventricle cells are contracting and they are giving blood to all body organs via aorta. So it is demand and supply relationship. So first heart, the left ventricle is demanding blood, that you give me blood via coronary. I will get blood, I will get oxygen, I will make ATP, I will contract, and when the cells of the left ventricle contract, they will give blood. The systole will happen. So they will give blood via aorta to all the organs, right? So this is demand and supply ratio. You got my point? So what is the supply? What is the demand of the heart? The demand of the myocardial cells is the blood you are supplying via coronary. And what is the supply? What is the supply of the myocardial cells? So whenever all these cells get blood via coronary, they make ATP, they contract, and when they contract, the blood comes in the aorta and get distributed to all the body organs. So demand is the blood given to the heart via coronary, and supply is the blood given by the heart via contracting of left ventricle via aorta to all body organs. So there is a balance between them. The ratio of the blood you are supplying via coronary, so more blood you are supplying via coronary, more oxygen, more ATP, more contraction, more vigorous systole, so more blood will come in aorta. If you supply less blood in the coronary, though all these cells will receive less oxygen. They receive less oxygen, they will form less ATP. They will form less ATP, systole will be less vigorous. Systole will be less vigorous, so the contraction of the left ventricle will be less vigorous. So less blood will come in aorta. So what it is the ratio, it is the balance between demand and supply. Does everyone got what is demand, what is supply? If yes, give me a thumbs up. What is demand, what is supply? Now, what is ischemic heart disease? In ischemic heart disease, you are giving less blood to the heart. You are obstructing the coronary. The coronary is obstructed by one or the other reason. There can be many reasons of the coronary obstruction. The most common is the atherosclerosis. Now imagine in this coronary, either there is atherosclerosis, or there is thrombus, or there is vasoconstriction of the coronary. Due to multiple reasons, the coronary is either partially or completely obstructed. So what will happen? The left ventricle cells will receive less blood. As I have told you, they all will receive less blood. So coronary is giving less blood, the cells will receive less blood because it is partially obstructed. So less blood means less oxygen. Less oxygen means they will form less ATP. If they will form less ATP, they will contract less vigorously and they will give less blood in the aorta. So that is the thing. But if you are demanding high, you are giving less blood to the coronary and asking the heart to contract at the same vigorosity and give same blood to the aorta. So imbalance occur between demand and supply, and that is known as ischemic heart disease. So this is the definition of ischemic heart disease. I want all of you to appreciate. What is the ischemic heart disease? It is the imbalance between the myocardial supply and myocardial demand. So when imbalance occur for the oxygenated blood, it is known as ischemic heart disease. First, everyone give me a thumbs up. Gaurav, Sufi, others, have you got it? What is ischemic heart disease? Now, before coming on the details of ischemic heart disease, under the heading ischemic heart disease, we are going to study 4 diseases today, one by one. Two are very important. I will teach you two in detail, the angina and the MI. Both I will teach you in detail. But before that, you should understand the coronary, the blood supply of the heart. So blood supply of the heart is via coronary. Coronary, the left coronary and the right coronary. There are two coronaries. We all know that. Left coronary artery, right coronary artery. Right coronary artery is known as RCA. Right coronary artery, it doesn't have any further branch. But left coronary artery, LCA, left coronary artery have two branches. What are the two branches of left coronary artery? It is LAD and LCX. LAD is left anterior descending and LCX is left circumflex. So total three coronaries are there in the end. Two are the branches of the left side and one is the right side. So we are having three coronaries. One is LAD, one is LCX. These two are the branches of left coronary artery. These two are the branches of left coronary artery, LCA. And the one is RCA, that is right coronary artery. So what is the full form? RCA is simple, right coronary artery, no further branch. But LCA is having two branches. So it is left anterior descending, LAD, and left CX, left circumflex, LCX. So total three coronaries are there, right? Total three coronaries are there. So we are having three coronaries. You can see the names. You can see it is left anterior descending LAD, left circumflex LCX, the two branches of the LCA, and one is right coronary artery, RCA, right? You can see the coronaries arising from the arch of the aorta, right? Now, see, this is a diagram of heart. See, everyone, please understand. If I am cutting the heart from here, if I am cutting the heart from here and looking the heart from above, if I am cutting the heart from here and looking the heart from above, what I will see? I will see the like this. Okay, I will see like this. Let me draw the diagram. I will see two lumens. This is right ventricle and this is left ventricle. Right? I have cut the heart and looking from above. So this is the cross-sectional area of the ventricles. At the ventricular level, I am cutting the heart. Now, I am interested in left ventricle because left ventricle is doing the systole and giving pure blood to the aorta. Left ventricle have four walls. See, everyone understand. This is the anterior wall of the left ventricle. This is the posterior wall of the left ventricle. This is the lateral wall of the left ventricle. And this is the medial wall of the left ventricle. On the medial wall, we are having interventricular septum. So actually, interventricular septum is the medial wall. You got my point? So there is anterior wall of the left ventricle, posterior wall of the left ventricle, lateral wall of the left ventricle, and medial wall of the left ventricle. So I am interested in the blood supply of the four walls. Now total we are having three coronaries. Please understand. Coronaries are three. Three coronary arteries we are having, right? And walls are four. We have to supply the four walls via three coronaries. So can you name them? Which coronary? What three coronaries we are having? We are having LAD, we are having LCX, and we are having RCA. We already know we are having three coronaries with us. The two are the left side, left coronary artery branches, and one is right side. Now, can you tell me which coronary supplies which branch? Okay, so anterior wall is supplied by LED. Most important. Anterior wall is supplied by LED. Please learn it. Please learn it. Lateral wall is supplied by LCX. Lateral is supplied by LCX. Right? And the posterior wall is supplied by RCA. Posterior is supplied by RCA. What about the medial wall? What about the medial wall now? Now come on the medial wall. I will tell you medial wall. Medial wall anterior. Now divide the medial wall. This is medial wall, no? I told you this is medial wall. Actually, medial wall is interventricular septum only, right? So in the medial wall, you can say anterior two-third is supplied by the continuation of this. That is LAD, right? And posterior one-third is supplied by the continuation of this. That is RCA. So it's very easy. I hope everyone got it. So Adra, Kishore, Sufi, Gaurav, have you got it? I can't see the name of others. Have you got it? All the students who are watching me right now, have you got it? What is the blood supply of the four walls of the left ventricle? Say yes or no. So total three coronaries plus four walls. So how three coronaries supply the four walls of the left ventricle? It is in front of you. So the same diagram is here. Now correlate. Here I have told you the diagram already. So you can see I'm cutting the heart at this level and I'm looking from above. You all can see this is the cross-sectional area. You all can see this is right ventricular cavity and this is left ventricular cavity. I am interested in left ventricle. Now see, the author, the one who has drawn this diagram, he has done the color coding. What is the color coding? See the anterior wall of the left ventricle. The anterior wall of the left ventricle is supplied by LAD. So this purple color is the LAD, right? It is LAD, right? The lateral wall is supplied by, can you see this is the blue color? It is LCX. So this is the LCX, the lateral wall. You can see. And the posterior wall, you all can see posterior wall is supplied by RCA. This is RCA, right? What about medial wall? You all can see medial wall. The anterior 2/3 is supplied by continuation of anterior wall and posterior 1/3 is supplied by continuation of posterior wall. That is anterior 1/3 is supplied by LED only and posterior 1/3 is supplied by RCA. Do you have any doubt in that? No? Shall I proceed? Now, out of the three coronary, I am saying one of the coronary or two or all three, whatever is obstructed. Now, the cause of obstruction can vary. It can be atherosclerosis, it can be thrombosis, it can be embolism, it can be vasospasm, focal. Now, whatever is the cause of the coronary, ultimate end result is that coronary is obstructed, right? Now, obstruction can be partial, can be complete. So, obstruction का cause कुछ भी हो सकता है, obstruction partial भी हो सकता है, complete भी हो सकता है. एक्यूट भी हो सकता है, क्रॉनिक भी हो सकता है, सडन भी हो सकता है, इंसिडियस भी हो सकता है. ओके, अल्टीमेटली देयर इज ऑब्स्ट्रक्शन. नाउ ऑब्स्ट्रक्शन आइदर इन वन कोरोनरी और टू कोरोनरी और ऑल थ्री कोरोनरी, व्हाटएवर कैन हैपन, एनीथिंग कैन बी द सिचुएशन. द पॉइंट इज दैट whatever coronary is obstructed, that wall of the left ventricle will not receive blood, right? Just suppose for an example LED is obstructed, right? So anterior wall and the medial 1/3 wall, medial anterior 2/3 wall, this portion of the heart will not receive blood. So this portion, whatever organ in human body do not receive pure oxygenated blood, that undergo necrosis, that undergo ischemia, infarction and ultimately necrosis, coagulative necrosis. You know that. So this wall, the cells of this wall start dying. They will be dead by necrosis. So ischemia, infarction and necrosis occurs in this wall, right? If LCX is obstructed, ischemia, necrosis occurs in lateral wall. And if RCA is obstructed, ischemia, infarction and necrosis occurs in the posterior wall, right? So this is how the point is that whatever coronary is obstructed, that wall will show MI. That wall will show MI. So it is very specific. Yes or no? Yes or no? Have you got it? Shall I proceed ahead? So let me tell you the summary till now and then I will proceed ahead. You can see the diagram of the heart. Let me cut the heart from here and look the heart from above. So what I will find? I will find a section like this. So you can see this is right ventricle. You can see this is left ventricle. You can see the four walls of the left ventricle. Okay, the diagram is gone. I'm really sorry. Just a second. You can see the four walls of the left ventricle. What are the four walls of the left ventricle? This is anterior wall, this is posterior wall, this is lateral wall, and this is medial wall. Actually, medial wall is interventricular septum only. Interventricular septum is known as medial wall. Now we are having three coronaries with us. So LAD, left anterior descending, supplies anterior wall, please learn it. LCX supplies lateral wall, please learn it. RCA supplies posterior wall, please learn it. So three coronaries, three wall. What about the fourth wall? We don't have fourth coronary. The fourth wall is the medial wall. So medial wall anterior 2/3 is supplied by continuation of the LAD, right? And posterior 1/3. Posterior 1/3, anterior 2/3, posterior 1/3 is supplied by continuation of the posterior wall, that is RCA. So this portion is supplied by RCA and this portion is supplied by LAD. So medial wall have dual blood supply, the double coronaries. Now depending which coronary is obstructed, it can be obstruction occur in LAD, it can be obstruction occur in LCX, obstruction can be RCA, obstruction can be atherosclerosis, thrombosis, embolism, vasospasm, obstruction can be partial, can be complete, whatever is the obstruction. The particular coronary supplying that wall will not receive blood, adequate blood. So that wall will undergo ischemia, infarction and coagulative necrosis and that is known as MI. That is MI. So MI can occur in this wall or in this wall. So MI occurs in which wall? That depends on which coronary is obstructed. You got my point? So in which wall am I? So what is the frequency of obstruction? So there are three coronaries as I have told you. So since I have told you there are three coronaries, so the sequence of obstruction, the incidence wise if I say, so most commonly LAD is obstructed. Then the second most commonly RC is obstructed and least commonly LCX is obstructed. So this is the sequence of their obstruction. This is incidence wise we have seen. Most of the cases LAD is obstructed. Second most common, RC is obstructed. Least common, we have seen very few cases in which LCX is obstructed. So tell me the sequence of the walls in which MI is formed. So mostly MI is in anterior wall. than in posterior wall, and very less common that you will find MI in lateral wall. So this is the sequence of the walls in which you will find the MI, that is myocardial infarction, the scar of the myocardial infarction. Everyone give me a thumbs up, everyone. So this is all basics. I am going to teach you the pathology. Of course, it is a pathology lecture. So before that, you should understand the anatomy. If you don't know the anatomy of the coronaries, the blood supply of the heart, you cannot understand ischemic heart disease. Everyone give me a thumbs up. Shall I proceed ahead? So the same thing is written in the form of the theory. Let me read the theory. So as I have told you, there are three coronaries. So see the details. The first coronary is left anterior descending. It supplies the anterior wall of the heart. It also supplies medial wall. Interventricular septum, medial wall ka anterior two-third, and it supplies apex, right? And it is most commonly obstructed. That is a summary of LAD. After LAD, we have seen this is LAD, right? You can see it is not only supplying anterior wall, it is supplying anterior two-third of the medial wall also, and it is supplying apex also. So that is the blood supply by the LAD, and it is most commonly obstructed. The second is LCX. LCX, it supplies only lateral wall, and it is least commonly obstructed. So we see this is LCX. It is supplying the lateral wall, and it is least commonly obstructed. The third one is the RCA. RCA supplies posterior wall, number one. It supplies posterior one-third of the medial wall. So RCA, you can see RCA, it is supplying posterior wall, not only posterior wall, posterior one-third of the medial wall also, right? Not only that, you have not asked me, ma'am, what about the right ventricle? You have not told the blood supply of the complete right ventricle. I'm telling you blood supply only of the left ventricle. The complete right ventricle is also supplied by RC, right? I forgot to tell you, right? So complete right ventricle free wall, complete. Usme anterior, posterior, I'm not doing so. So complete right ventricle is supplied by right coronary artery, and it is second most commonly obstructed, right? So what is the sequence of obstruction? It is the sequence of obstruction is like this. So you can say the two left there are two branches. You can learn like this. This is the first branch of left, LAD. This is the second branch of left, LCX, और उन दोनों के बीच में लिख दो RCA, right? So RC is in the between the two branches of the left. So you will never forget the two branches of the left and RCA in the center. So you can say this is the sequence of obstruction. LAD most common, RCA second most common, LCX least common. Now you can tell me the wall which is they are supplying. So LAD supplies anterior wall, RAD supplies posterior wall, RCA, and LCX supplies lateral wall. We all know that. We have already discussed. So this is the sequence of MI. We have discussed that, right? Now, in some humans, it can happen only one coronary is obstructed. It is known as single vessel disease. In some humans, two vessels are obstructed, and in some persons, patients, all three coronaries can be obstructed. It is known as triple disease, right? So bypass surgeries and CABG, these will be the treatment options in such patients. Okay. Anyways, now let me come on the effects of ischemic heart disease. Till now, what we have understood? We have understood what is the definition of ischemic heart disease. Now you got it. Why ischemic heart disease is also known as coronary artery disease. You tell me the reason. For telling the reason, you tell me the definition of ischemic heart disease. What is ischemic heart disease? I told you the definition. Actually, it is imbalance. It is imbalance between demand and supply. It is imbalance between demand and supply of the heart. I have already taught you that what is demand of heart, what is supply of heart. If you understand the demand and supply of the heart, normally there is a balance. The demand is equally proportional to supply. But if you are giving less to heart and asking for more work, so heart will not do that, and it will result in a disease that is ischemic heart disease. Ischemic heart disease always results due to the obstruction of one of the coronary. There are three coronaries. So anyone can obstruct. We know the sequence of their obstruction. That's why ischemic heart disease are also known as coronary artery disease. It is one and the same thing. Because the coronaries get obstructed, it will lead to ischemia. So that's why coronary artery disease leads to ischemic heart disease. One and the same thing. So these two are the synonyms, right? दो अलग अलग नहीं है, same ही disease है. Ischemic heart disease और coronary artery disease एक ही बात है. And the definition of both of them, there is imbalance between demand and supply of the heart. Give me a thumbs up. You got my point? What is the demand and supply of the heart? Now, whenever any of the coronary is obstructed, it is known as ischemic heart disease. Four things can happen. Either the patient have angina pectoralis, or the patient will have MI, myocardial infarction, or the patient have chronic ischemic heart disease, or the patient has sudden cardiac death. So these four things are included under, these all four do not occur at the same point. Either of the patient can present with anyone, right? So the most unluckiest patient, it can be sudden cardiac death, right? It can be chronic, it can be angina, it can be MI. So that is the spectrum of ischemic heart disease. So ischemic heart disease is not one disease. It is a spectrum or it is an umbrella term including all four. So what does ischemic heart disease include? Ischemic heart disease includes four things. I will explain you the difference between the four. Don't worry. So it includes one of the four things. So if the patient have obstruction in the coronary artery, in any of the three coronary arteries, there are three coronary arteries. So either the patient will have angina pectoralis, or the patient will have MI, or the patient have coronary artery disease, chronic disease, chronic heart disease, or the patient has sudden death. And these all are included under ischemic heart disease. Now you will say, ma'am, how the obstruction of the coronary can result in one of the four? Why there are four possibilities? Why? If the coronary is obstructed, why there are four possibilities? Okay. For this, I have to again explain you this diagram. Just a second. Let me come on the diagram. Let me show you. Yeah, this diagram. So can you all can understand this diagram now? I guess you all can understand this diagram now, right? Now, what is the demand and supply? Once again, I am repeating. You all can see in this diagram, this is the left ventricle, right? This is the left ventricle. Now listen, whenever left ventricle is contracting, the left ventricle contains pure blood, oxygenated blood. So that is coming in aorta. And via aorta, the pure and oxygenated blood is distributed to all the body organs. So this is the supply of the heart. Heart is supplying to all organs. The supply of the heart. This is the supply of the heart. The heart is supplying to all organs. But heart, how the left ventricle is contracting? Have you ever thought? It is the systole of the left ventricle which is giving blood to all organs. Whenever heart is doing systole, the left ventricle is doing systole, then only blood is coming. For doing systole, there are cells present in the wall of the left ventricle. These are myocardial cells. Can you see? These all are myocardial cells. They contract, then only systole will happen. If they don't contract, systole will not happen. But for contraction, they require ATP, and they can synthesize ATP from oxygen. For oxygen, they also require blood. So if you want the heart, the left ventricle basically to do contraction, you have to give blood to the cells of the left ventricle. So who will give this blood? This blood is given by the coronary. Now in this diagram, you can appreciate this is coronary. We have already discussed this is the coronary. This is the coronary artery. This is the conductance vessel, the bigger coronary, and these are the small resistance vessel which are supplying the wall of the heart from outer to inner. Now I am insisting on the word from outer to inner. If you understand from outer to inner, you will understand the two types of MI. I will discuss that, right? It is from outer to inner, just remember that, right? Now you can see these are the cells. Let me draw the cells in the wall of the left ventricle. All these are receiving blood from the coronary, and coronary is a branch of aorta only, so it contains pure blood. So all these cells are receiving blood via coronary. That's why they receive oxygen via coronary. That's why they can synthesize ATP. That's why they can contract. When they can contract, systole will happen. So the amount of blood, if you are giving more blood via coronary, more oxygen, more ATP, more vigorous contraction, more vigorous systole, and heart will give more blood to the aorta, and all the oxygen will receive more blood. So if you are giving more blood to the coronary, heart will give more blood via aorta. If you are giving less blood via coronary, if you are giving less blood via the coronary, if the coronary is obstructed, so you are giving less blood to the heart, less blood to the cells of the left ventricle. So they will receive less oxygen. If they will receive less oxygen, they will synthesize less ATP. If they synthesize less ATP, they will contract less vigorously, less vigorous systole, and less blood will come in aorta. So this is known as demand-supply relationship. So whatever is the demand, the proportionate should be the supply, right? So whatever you are giving, that only you can ask for that, right? So someone is having there is an employer and there is an employee. So whatever payment you are giving to the person, so that much work you can demand. You cannot say I will pay less but ask for more, or I will pay more and ask for less. So there is always a demand supply ratio in this world, and demand supply is a rule of this universe. Whatever you give, that only you take back, right? Now, whenever, if the coronary is obstructed, imagine if the coronary is obstructed, so you are giving less blood to the heart, but you are demanding for more. So that is the imbalance, and that is against the laws of universe, right? You are giving less and asking for more. No, this cannot happen, and it results in a disease known as ischemic heart disease, right? You tell me what I have to tell you. Okay. Matazilo, what you want to ask? Ask me. I am not how to get updates of the class. The updates of the class are already on the Telegram group. Dr. Rajat already told you. What about else? Anything else you want to ask? You can see the name of the class. It is written. It is MI Angina Pectoralis. Kishore already told you. So what is weird about that? Can you tell me? Can I continue? If you have any doubt, you please write down. Once I'm in the middle of something, I cannot leave that all of a sudden out of the blue and interact with you. So if you have any doubt, please write down in the chat box. I will be finishing one of the topic. I will have a look on the chat and reply you. So it's not weird. So sorry if I have missed any of your question. I'm really sorry for that. Anyways, let me continue here. So this is how I have told you. Now I am telling you why there are four possibilities. So if you can see, if the obstruction is temporary, if this obstruction is temporary, if the obstruction is occurring here, so and so it is hindering the blood supply of the left ventricle. But after some time, it just goes away. So it results in angina. This is angina. It results in angina pectoralis. In angina pectoralis, the obstruction is not permanent, it is temporary. So permanent ischemia do not occur, transient ischemia occur. And if this obstruction is permanent, it is permanent here, it is not going. So it results in the necrosis of the wall of the left ventricle. It results in MI. It results in MI. So in angina and MI, the obstruction is sudden, but in angina, it is temporary. In MI, it is permanent. So that I am going to teach you in detail. So let me start angina now. Just a second. So I am starting angina right now. So the next heading I'm starting is one of the ischemic heart disease. One of the ischemic heart disease, that is angina pectoralis, right? So in angina, you have to understand two things, the definition and types. So what is the definition of angina? Can you see this diagram? What is the definition of this angina? Angina is chest pain. Simply, it is chest pain. Not say pain, it is chest discomfort. Don't say the word pain. It is chest discomfort. Because actually the patient say it is not pain, it is the heaviness. It is the heaviness or the squeezing feeling in the chest. That is known as chest pain or chest discomfort. That is angina. So listen, what is angina here? Angina is a disease which is not continuous. It comes in attacks. It comes in attacks like asthma. Asthma is a disease, it is not continuously present. So the attack comes, the attack goes. The attack comes, the attack goes. And between two attacks, the patient is absolutely normal. Between two attacks, the patient is absolutely normal. These are the attacks. These are the attacks. So angina is a disease which comes in attacks. At the time of attack, patient have chest discomfort. And otherwise, between two attacks, patient is absolutely normal. That is the disease angina. I will tell you the pathogenesis, why it is happening, and I will tell you the types also. First, give me a thumbs up. Have you got it? So angina. Now, what is the attack known as in pathology? In pathology, the word attack means paroxysmal. Paroxysmal means attack. So can I say that angina is a paroxysmal disease? Yes. So any disease which is coming in attacks is known as paroxysmal. So angina is a paroxysmal disease in which recurrent attacks of pain, or not pain, chest discomfort is coming to the patient. So patient has substernal discomfort. Substernal, just below the sternum. You can see here, just below the sternum, patient have discomfort. Or precordial, that is just above the heart. Either say just below the sternum or just above the heart, one and the same thing, right? So either say substernal or say precordial. Chest discomfort, which is caused by, the word to be picked here is transient MI. It is transient myocardial ischemia. It is not permanent. If I remove the word transient and replace it by permanent, it is no more angina, it will become MI. So that is the only difference between the two. So it is the transient myocardial ischemia, right? So okay, I will tell you, have you got it? So patient comes to your clinic, doctor, I'm having chest discomfort. Only that thing. So it is not continuous. If it is MI, it will be continuous. So if it is angina, it is not continuous. So it will come, it will go, right? Okay. So again, angina is one of the ischemic heart disease. So it is imbalance between demand and supply. So you are giving less blood to the coronary, but you are asking for more. So that is the imbalance between demand and supply that results in angina. That is the basic definition of ischemic heart disease we have understood. Now coming on the types of angina, there are three types of angina. There are three types of angina. Stable angina known as classical angina, unstable angina known as crescendo angina, and transmental variant angina. There are three types of angina. Please understand the difference between them, because the treatment of all three angina is different. But the complaint is same. Patient comes with chest discomfort, that's all. Chest discomfort, that's all. So complaint is same. It is angina, but the treatment is different because the pathogenesis of the three type of angina is different. Let me start with the first one, the stable or classical. Stable or classical. Please learn other names also. Stable is known as classical, unstable is known as crescendo, and transmental is known as variant. So there are two names given to each angina. Let me start with the first one, stable or classical. Out of the three type of angina, this one is the most common type of angina. Out of the three types of angina, this one is the most common type of angina. See what is the problem here. It is shown in this diagram. If you can zoom the image, if it is possible for you, you can see in the coronary, I have shown atherosclerosis here. So one of the, you know that there are three coronaries. One of the coronary, there is atherosclerosis that is causing partial obstruction, not complete. It is causing partial obstruction in the coronary. Give me a thumbs up. So there is reduction in the coronary perfusion, right? There is reduction in the coronary perfusion because of the plaque formation. Plaque is atherosclerosis formation. So what is happening? Listen now. Please understand the story. It's very interesting. So the coronary is partially obstructed, but it is not complete obstructed. So just suppose initially when no atherosclerosis was there, you was giving 100% blood to the left ventricle via coronary. But now due to the partial obstruction, you are able to give only 70% or 60% of the blood to the left ventricle wall. Right? You got my point. So whenever you are reducing the coronary blood, so heart will contract, the left ventricle will contract less vigorously. The left ventricle will receive less blood, less oxygen, less ATP, less contraction. So less blood is given to the aorta. Of course, in that proportion. Initially 100% of the blood was coming in the aorta. Now only 70% will come. Whatever it was coming initially. So it is in that proportion only. That is the demand supply ratio. Right. Now you are reducing. So heart is also reducing. Right. So less blood will receive by all the organs. But that blood which is less, of course, instead of 100 it is only 70%, but that is sufficient for rest. If I'm resting, not doing anything, so that much blood is sufficient for my body organs, so I don't have any problem. So in my heart, just suppose I'm the patient, in my heart, in my coronary, one of my coronary is partially obstructed by atherosclerosis, so the wall of the left ventricle receives less blood, so it will contract less vigorously. So less blood will come in aorta. So all the body organs will receive less blood. But that much blood is sufficient for rest. So patient don't have any problem for rest. But suppose if the patient started running, started jogging, started any physical activity which increases the demand of the organ. While running, jogging or increasing physical activity, so all the organs require more blood because the muscles are contracting while running, and so they require more blood. So organs will demand more blood to the aorta. Aorta बोलेंगे और blood लाओ. We require more blood. You bring more blood from the left ventricle. So aorta will ask the heart, can you give me more blood? The organs are demanding more blood. You contract more vigorously. I want more blood. Organs are demanding that. Heart say no. You are not increasing the blood supply. You are giving me same blood supply. That is only 70% of the total. So I can give you the same blood supply. I cannot give you more. So at the time of exertion, so what will happen? You are demanding more but supplying less. So at the time of exertion, there is imbalance. At the time of rest, it is a balance. At the time of rest, you are giving less, you are asking less. It's okay, there is no problem. But then at the time of exertion, you are asking for more blood, but you are giving the same less blood. You are not increasing blood at the time of exertion because the wall of the coronary is atherosclerosed, it cannot dilate. Normally in a healthy person, whenever, just suppose currently we all are resting, we are not running, right? So whatever our heart, the coronary is supplying to the left ventricle, it is less, and all the heart ventricle is also contracting less, all the organs are receiving less. But once we start any physical activity, running, jogging, so at that time the coronaries dilate, vasodilatation occurs. So first we give more blood to the heart, then we ask for more. We cannot directly ask for more. So first you give more, then you ask for more. It is a rule of universe. First you give, then you ask, then you take, right? So we will give more. But here coronary cannot dilate because in the wall of the coronary there is atherosclerotic plaque. So coronary cannot dilate. You are giving same blood to the heart and asking for more at the time of physical exertion. So basically imbalance occur. What will happen? Imbalance. And imbalance lead to ischemia in the wall of the heart. You can see the wall of the heart, the wall of the left ventricle, these are the cells. Myocardial cells I am drawing. So they will receive less blood and they are contracting more vigorously. So due to imbalance, transient ischemia occur. And that transient ischemia leads to chest discomfort. So patient I'm feeling like chest pain, chest heaviness, chest discomfort because of the word transient ischemia. Why I'm using the word transient ischemia? As soon as the patient have chest pain or chest discomfort, whatever, patient will sit down. And once the patient is in rest, the pain disappears. So pain is coming only at the time of exertion. At the time of rest, it disappears. So ischemia disappears. So it is transient. It is not permanent. Everyone give me a thumbs up. Have you got it? Everyone give me a thumbs up. So what is stable angina? What is the problem in stable angina? You tell me. Out of the three types of angina, first thing, there are three types of angina. Out of the three types of angina, this one is the most common. Number one. In this, there is reduction in the coronary perfusion due to the plaque rupture, due to atherosclerosis, but it is partial. So patient have chest discomfort. It is not chest pain, it is discomfort. I'm insisting on the word discomfort. Discomfort means if you ask the patient what you are feeling, so patient will describe, I'm feeling heaviness in the chest. I'm feeling some pressure inside the chest. I'm feeling a squeezing feeling inside the chest. I'm feeling a choking feeling inside the chest. Or I'm feeling a smoothing feeling. But it is not pain, right? Chest discomfort occurs only at the time of exertion and it is relieved by rest. So only at the time of exertion, patient have chest exertion. At the time of rest, it disappears. So this is a classical finding in classical angina or stable angina, right? If you ask the patient to localize the sensation, how you are feeling, please localize your feeling. So patient what will do? Can you see this is my hand? I'm making a fist, clenched fist. It is known as मुट्ठी बांधना. That is clenched fist. Patient ऐसा करेगा और कहेगा कि यहाँ पे मुझे कुछ ऐसा हो रहा है. I'm feeling something like this here on the chest. So this is known as Levine sign. Patient will do that. So if you ask to describe the feeling, patient will do the clenched fist, मुट्ठी बांध देगा और कहेगा कि कुछ ऐसी वाली feeling है. That is some squeezing feeling is there, right? And pain typically lasts for only 2 to 5 minutes. After 2 to 5 minutes, the pain disappears because patient is taking the rest, right? And it is crescendo, decrescendo in nature. So first pain increases in intensity, and then once the patient is on rest, the pain decreases in intensity. So this is the classical scenario of the first type of angina. Everyone give me a thumbs up. That is the first type of angina, classical or stable angina. Have you got it? Adra, Kishore, Fernando, others. Have you got it? Give me a thumbs up. Everyone. Yes? Shall I move ahead? So coming on the second type of angina. The second type of angina is unstable angina. What is unstable angina? Here you can see in the diagram only one change. So in the coronary, instead of atherosclerosis, it is thrombosis now. Instead of atherosclerosis, now it is thrombosis, which is all of a sudden causing complete obstruction, right? So disruption of the atherosclerosis leads to thrombosis. That leads to unstable angina. Now, what is the clinically how it differentiates? Clinically, here also patient have discomfort, but it continues on rest also. So there is no change while exerting or while on rest. In contrast to classical angina, where patient have discomfort only at the time of exertion and it disappears at the time of rest. It is not happening here. It can occur at the time of rest also. Classical angina, the discomfort was lasting for 2 to 5 minutes maximum. Here it is lasting more than 10 minutes. The pain is severe and new onset, and it is continuously increasing in intensity. It is not increasing and decreasing. It is continuously, and patients say it is pain. Instead of discomfort, yeah, it is a pain. In classical one, it was a discomfort. So what are the differences between the first classical or stable angina and the second one I am teaching you unstable angina, right? So what are the differences, can you tell me? Here typically pain occurs on exertion and it disappears on rest it disappears. Here pain continues on rest, the biggest difference clinically, right? This one occurs due to atherosclerotic partial obstruction of the coronary. This one occurs due to all of a sudden thrombotic obstruction, right? So that is the difference. One more difference, here pain lasts for 2 to 5 minutes. Here pain lasts for more than 10 minutes. One more difference, here pain is crescendo, decrescendo. That is the nature. Here it is always crescendo. That is new onset. Everyone give me a thumbs up. Everyone, shall I move ahead? Yes. So these are the differences. The third and the last type of angina is transmantle angina, also known as variant angina. Transmantle variant angina. So what is the problem? See, I have shown clearly the diagram. Can you zoom this portion and see what is the problem in the coronary? Here, there is no atherosclerosis in the coronary. There is no thrombosis in the coronary. Focal vasospasm of the coronary. Focally, one portion of the coronary undergoes spasm all of a sudden. The reason can be anything, and all of a sudden it is undergoing vasospasm, and after some time automatically it will vasodilate and become normal, right? So vasospasm, the spasm of the coronary, mostly it occurs in right coronary. It is the reason. It again can, क्योंकि spasm तो कभी भी हो सकता है ना, spasm can occur at rest also, exertion also. So it is not related to physical activity, right? So these are the three type of angina we have discussed. Have you got it? Angina pectoralis. So what we have learned? We have learned ischemic heart disease present in one of the four presentation. So either the patient presents with angina pectoralis, or the patient presents with MI, or patient presents with chronic heart disease, or patient presents with sudden death. So this is the spectrum of ischemic heart disease, also known as coronary artery disease. We have started the first one, angina pectoralis. In that we have seen what is the definition. The definition is same. It is the imbalance between demand and supply of the heart. But here the obstruction is transient. The obstruction is transient, and because of which the ischemia is transient. So patient have chest discomfort, but that is transient. It is not persistent, right? And here it is of three types we have seen. What are the three types of angina we have seen? We have seen stable angina. We have seen stable angina, unstable angina, and the third type of Prinzmantle or variant angina. In the stable angina, the problem is the atherosclerotic plaque. Here the problem is the thrombosis, and here problem is vasospasm. Yes, Adra, mostly it is in RCA. Most commonly it is in RCA. So although this type of angina is very rare, और उसमें भी RCA में most common होता है, but it can happen in any coronary. But mostly in most of the 90% of the cases it is in RCA, I can say. Have you got it? Shall I move ahead? So that is the angina we have seen, right? Now coming on the most important topic, MI, the second presentation of ischemic heart disease. We are done with angina. I am starting myocardial infarction, MI. Are you people with me? Everyone give me a thumbs up, those who can watch me live right now. Everyone. Can I start MI? I am going to teach you MI in detail under the following headings. First of all, I will tell you what is MI. What is the definition of MI? How you define MI, right? Then I will teach you etiopathogenesis of myocardial infarction, types of infarct, location of infarct. Most important is the morphology of infarct, the gross and microscopy on which maximum MCQs come. Make 5-star over it, right? Maximum. So it is the most difficult portion to understand in MI. I will teach you this in much detail, right? After that, you already know clinical features of MI, diagnosis of MI, complications of MI, and salvage therapies in MI. So we will study everything about MI in this lecture. Shall I move ahead? So let me start with the definition of MI. What is the definition of MI? What is the definition of MI? So again, MI में क्या हो रहा है? What is happening in MI? It is the necrosis of the wall of the left ventricle, of the myocardial wall. The wall of the left ventricle is taking place due to decreased blood supply to the wall of the heart. If there is atherosclerosis, it is complete atherosclerosis this time. It is not partial. In angina, it was partial. In the first type of angina, the classical angina, the atherosclerosis was partially obstructing. Here, the atherosclerosis is maximum, more than 90% it is obstructing, right? Or maybe completely obstructing. So, it is the obstruction, not only atherosclerosis, it can be thrombosis, it can be vasospasm. The thing is that it is persistent. It is not going. It is not going. So, here there is obstruction in the flow of the blood flow. So, the left ventricle wall is receiving less blood. The left ventricle wall, the cells of the left ventricle wall are receiving less blood, and it is persistently less blood. So after few hours, the cells start dying. The cells start dying. Now which cell will die? Depending which coronary is obstructed. I told you there are three types of coronaries. LED supplies anterior wall, RCA supplies posterior wall, and LCX supplies lateral wall. You know it crystal clear. So the one which coronary is obstructed, the cells of that particular wall will start dying. The cell will become dead by necrosis. By coagulative necrosis. We know that when any part of human body do not get blood, in that portion, the cells of that organ will undergo death by coagulative necrosis. So coagulative necrosis is occurring in heart, because this time heart is the organ which is not receiving blood because of the obstruction in the coronary. If the coronary is obstructed, any of the three coronary is obstructed, that wall of the heart, the cells of that wall will not receive blood and they undergo ischemia and coagulative necrosis. That is known as MI, and it is irreversible. Like angina, it is not reversible. So it is irreversible. Once necrosis occur, it is irreversible. So it is persistent ischemia. It is not transient ischemia like angina. You got my point? Etiopathogenesis is the same as that of angina. So it can be atherosclerosis in one of the coronary, it can be thrombosis in one of the coronary, it can be non-atherosclerotic causes, means vasospasm of one of the coronary, but the obstruction is complete. Now I'm coming on the type of the infarcts. To understand the type of the infarct, see this diagram carefully. So please everyone see this diagram. Can you all see this is the coronary I am talking about? This is the bigger coronary. Can you see it is arising from aorta? So coronary is a branch of aorta. Can you all see? Yes, this is the bigger coronary arising from the wall of the aorta, from which multiple small coronaries are arising and supplying the wall of the heart. Supplying the wall of the heart from outer to inner side. See, this is the lumen. You all can appreciate this is the lumen of left ventricle and this is the wall. So this is the inner side. This is the inner side of the wall and this is the outer side. So coronaries are supplying blood from outer to inner. So let me take and let me zoom this portion. I'm drawing only this portion on the next page. So in this page, I'm drawing the wall of the left ventricle. On this page, I'm drawing the wall of the left ventricle. This is the wall of the left ventricle. You can appreciate this is lumen containing blood, right? You can appreciate here I am drawing the coronary. This is the bigger coronary, that is conductance vessel, and from which small resistance vessel are coming inside. These are small vessels which are coming inside, that is resistance vessel. They are supplying the wall from outer to inner side. You can see this is lumen. So this portion is inner. It contains blood. And this portion is outer. Heart has three layers. I have drawn only one layer. What are the three layers of heart? Endocardium, myocardium, pericardium. So endocardial cells are there. This is endocardium on the inner side. These cells I am drawing endocardial cells. Like blood vessel, it is endocardium. This is complete myocardium, the thickest layer. And this is pericardium. Pericardium is a thin layer, outer surface, right? This is pericardium. Everyone give me a thumbs up. So endocardium, myocardium, and pericardium. Endocardium, myocardium, pericardium. In the myocardium, I am drawing myocardial cells. These are the myocardial cells I want to draw here. Few cells I am drawing. So myocardium is the thickest layer. Give me a thumbs up. Myocardium is the thickest layer. So what are the three layers of the heart, you tell me? Endo, myo, peri. Can you see the three layers in this diagram? Yes, you all can see. Endocardium I have shown by these cells. These are the endocardial cells. Can you see? These are the endocardial cells. Myocardium is the thickest layer made up of myocardial cells, the green cells. And pericardium is the outermost layer. So outermost thin covering is the pericardium. See, the myocardium is divided into two parts, right? The portion of the myocardium, this inner portion, inner two-third portion of the myocardium, which is just below the endocardium. The portion of the myocardium which is just below the endocardium. This portion is known as subendocardial myocardium. It is myocardium, but it's below subendocardium. That's why known as subendocardial myocardium. You got my point? And the outer one-third portion of the myocardium. Outer one-third portion of the myocardium, which is just below pericardium. This is pericardium, no? This is pericardium. Yes or no? Yes or no? So just below the pericardium, this portion of the myocardium is known as subpericardial myocardium. Subpericardial myocardium. So basically, we are dividing myocardium into two portions, the inner two-third and outer one-third. Inner two-third is below endocardium, that's why known as subendocardial myocardial portion, and outer one-third is just below pericardium, that's why known as subpericardial myocardium. Give me a thumbs up on this point if you got this point. Now concentrate. Everyone give me a thumbs up. Adra, awesome. Have you got it? Dayaram, what you are asking, renal pathology episode 5, 6 on YouTube or not? You just write the exact topic, Dayaram, you want. Exact topic of the renal, because half of the sessions I am taking on YouTube and half I am taking on the special classes of Unacademy. So which topic you want in renal pathology? I have not covered tumor yet in this batch, but I can send you the recordings of the last batch. For this batch, the tumors, no, I have already taken the tumors in the last batch. Yeah, I've taken. I can send you the links. The links are available on the special class, not on YouTube. So please tag me on Telegram. I will share you the links of renal pathology episode 5 and 6, which exact topic you want. Anyways, let me continue here. What I was telling you, I was telling you, please concentrate on the coronary now. Please concentrate on the coronary now. These are the small coronaries. I will do the obstruction in the bigger coronary. In the bigger coronary, in the conductance vessel, let's do the obstruction. Let's do the obstruction. So this is the bigger coronary. Let me obstruct it here. So this is the blood supply hindering, or let me do the obstruction here. So less blood is coming here. So all these small coronaries receive less blood because the bigger coronary is obstructed. Now you tell me, when less blood is coming in the smaller coronaries, all the smaller coronaries receive less blood as compared to normal. So myocardial cells will start necrosing, will start dying, will start showing necrosis. So which portion of the myocardium, that is subendocardial myocardium or subpericardial myocardium, will start the necrosis first? पहले necrosis कहाँ होगा? The necrosis or cell death will start at which endocardium, which myocardium? Common sense. At which myocardium? Does it occur at subendocardial myocardium first, or does it occur at subpericardial myocardium first? You can see the blood supply. The diagram is in front of you. Can you tell me with a reason? Why, Kishore? You are absolutely right, Kishore. It is subendocardial, but why? It is subendocardial, but why? So you can see this is the smaller coronaries. They are supplying the blood from outer to inner. So when they are supplying blood from outer to inner, you can see the arrow. This blood supply is from out. So outer portion is having more blood. And while going, jab tak andar jate, we are going inner, the blood is becoming less, right? So whenever there is obstruction in the bigger coronary and there is less blood, the inner portion is compromised first. Inner portion. That's why infarction always start, it is a rule, from the subendocardial myocardium. So imagine this portion is getting infarcted. So it started here. So this infarct is known as subendocardial infarct. So infarct is in the subendocardial. But imagine the obstruction is continued. It is continued. So this infarct will elongate, enlarge, and gradually it will involve the complete wall. This is known as transmural infarct. So infarcts are of two types. At the initial level, infarct occur only in the inner portion, only in the inner myocardium. Such infarct are known as subendocardial infarcts. That is, they are occurring in subendocardial myocardium portion of the myocardium, and gradually it will progress and involve the continuous the throughout the wall. When full thickness infarct are there, such infarct are known as transmural. Understand the meaning of transmural. Trans means full, mural means wall, full wall infarct. So there is no subpericardial infarct. Subpericardial alone कभी नहीं होगा. या तो subendocardial होगा या full thickness होगा. So infarcts are of two types: subendocardial and full thickness. That is transmural. Give me a thumbs up on this point. Everyone, give me a thumbs up for this point. Yes, Prashant, absolutely right. The distance is long. Yes. So have you got it? So the two type of infarcts are in front of you. So initially it will be subendocardial. That is when only inner endocardial half of the myocardium will have infarct, and gradually it will be full thickness. That is known as transmural. Trans का मतलब होता है full और mural का होता है wall. So full wall thickness, right? So entire thickness of the wall will be involved. Everyone give me a thumbs up. So you can see the two type of infarcts in this diagram. You can see we have cut the heart at this level and we are looking the heart from above. So we are looking, this is right ventricular cavity, this is left ventricular cavity. You can see in the left ventricular cavity, I am interested in left ventricular. In the left ventricular cavity, you can see I am drawing endocardium. The red color is the endocardium. These are the endocardial cells, right? This is endocardium. The green color is the myocardium. So this is complete myocardium. This is complete myocardium. Pericardium is a thin layer. Outer you can draw, this is pericardium, right? Now in the myocardium, yellow color is the infarct. Can you see this is the infarct here? It is starting from the endocardium. So this infarct is subendocardial infarct. And gradually it will progress and involve the throughout the thickness. So in that point, it is known as transmural. Sometimes it can be random. It can be random, very, very rare of the rarest. So it is known as laminar. So basically infarcts are of two types. Now the best diagram from Robbins for this context, I found out this. I will explain you this diagram. Can you zoom the image? I guess you can't zoom the image. Anyways, I will try to explain you. See this image with concentration on your gadgets. See, everyone see. What is this in this diagram? The image is from Robbins only. So you can see this is the left ventricular wall. The wall of the left ventricle, this is the lumen. This is the lumen. You can see the inner side, the outer side. See in the wall, see this is the coronary. One of the coronary is there, which is having obstructed. Just obstructed to 0R. So this is obstructed right now. So there is atherosclerosis, vasospasm, anything. So at 0, there is no infarct. Because just now coronary is obstructed right now. So infarct has not yet started. But after 2 hours, if you see the same coronary, if you see the same diagram, you can see this is the left ventricular wall and this is the, here also, let me draw the left ventricular wall once for all, and you can see the coronary. You can see the coronary which is obstructed. So at 0R, I can't see any infarct. But at 2R, I can see the infarct started on the inner side. Can you see this is the infarct? So this is subendocardial. But if the obstruction continues after 24 hours, oh my God, after 24 hours, I can see full thickness infarct. The patient have not taken any treatment and the patient is having full thickness infarct. Now please tell me, have you got the difference? Have you got the difference? So this is subendocardial infarct and gradually it got converted to transmural. At 0R, nothing is there. At 2R, and subendocardial is there. And at 24R, transmural is there. Everyone give me a thumbs up. Come on, at least respond. I'm asking you. Have you got it? Everyone? Gautam, Kishore, Prashant, Awesome, Adra, everyone. Right? Shall I move ahead? So this is the two type of the infarcts. So we have learned there are two type of infarcts. Transmural, that is full thickness. It is full thickness infarct. And subendocardial, only inner third or inner 1/3 of the myocardium will have infarct. Transmural are more common. Gradually, most of the patients we found, they come at the stage of transmural to the hospitals. And subendocardial are less frequent because patients don't have symptoms when only inner half is infarcted. The rest of the myocardial cells are taking care, right? But whenever full thickness infarct is there, at that time patient comes with the symptoms and he runs to the hospital, right? Distribution we already know, okay. Okay. So coming on the location of the infarct, I don't need to explain you this point, I guess. The location of infarct depends on the type of the coronary, on which coronary, which branch of the coronary is obstructed. We already know there are three type of coronaries. One is right coronary artery and two are left coronary artery. Left coronary artery have two branches, that is left anterior descending and left circumflex. So which coronary is obstructed, depending on that, that will be the location of the infarct. Right. So once more for the revision, if we see, if we are cutting the heart from here and looking from above, we all can see this is right ventricular lumen, this is left ventricular lumen. See the walls of the left ventricle. This is anterior wall of the left ventricle. This is posterior wall of the left ventricle. This is medial wall of the left ventricle, and this is I'm sorry, this one is lateral wall of the left ventricle, and this one interventricular septum is the medial wall. Right. Just for the sake of revision, I will show you the diagram from the Robbins right now after this. So, okay, this is right ventricle, this is left ventricle. You already know that, I know. So, this is anterior wall, this is lateral wall, this is posterior wall, and this is medial wall. Actually, medial wall is the interventricular septum. You already know the coronaries. Can you tell me the name of the coronary which supply anterior wall? What's the name of the coronary which supply anterior wall? It is LAD. We have already discussed. What's the name of the coronary supplying lateral wall? It is LCX. What's the name of the coronary supplying posterior wall? It is RCA. We know that. And medial wall, we know that anterior two-third of the medial wall is supplied by LAD only, and posterior one-third of the medial wall is supplied by RCA. So medial wall is the only wall supplied by double coronaries. So we know that. Now whatever coronary is obstructed, that portion will have MI. So that will be the location. That will be the location, right? Let me show you a diagram. The best diagram again in this context from Robbins. Can you see this diagram? Please concentrate on your gadgets. I want to teach you a very beautiful thing here. Listen, very important point. Now please read the entire chapter, the entire topic ischemic heart disease today only from Robbins. It will be cakewalk for you. It will be most easy thing for you. So just after watching this lecture, please open the Robbins and read it completely. So you will understand everything now. Listen now, listen. So you can see here what I am showing you. See, understand this is the normal diagram of the heart. Can you see this is the lumen? This is the diagram, cross-section diagram of the heart. The two cavities. This is right ventricle. This is left ventricle. You can see the two cavities. I guess everyone can see the two cavities, right? Please appreciate the three coronaries. This is anterior wall. So I guess no need to tell this is LAD. I guess you already know that. Robbins is considering that you already know that's why it is not labeled. Right. This coronary is lateral wall. That's why it is LCX. No need to tell. Right. And this is the posterior wall. So this coronary is RCA. I guess it is common sense and every student knows it. Right. Now see, in these three diagrams, can you see here three diagrams are shown to you? Three diagrams are shown to you here and three diagrams are shown to you here. Right. What is the difference in them? I will do the obstruction of the coronaries one by one. Can you see in this diagram, this coronary is completely obstructed and here the same coronary is partially obstructed. The same coronary is partially obstructed. So which coronary is obstructed? In both of them, I'm talking about this diagram and this diagram parallelly. These two diagrams I'm talking about. These two diagrams. Which coronary is obstructed? It is LAD on the anterior wall. When it is completely obstructed, C, infarct is transmural. Transmural, yes. The infarct is transmural. And when it is partially obstructed, the infarct is subendocardial. Beautiful diagram. Means diagram itself speaking everything, elaborating anything, no need of any text, of no need of any description. It is self-descriptive diagram. It is shown in the diagram that when LAD is completely obstructed, it is transmural infarct, and when LAD is partially obstructed, it is subendocardial infarct. Give me a thumbs up. Everyone give me a thumbs up. Coming on the next coronary. Come on, give me a thumbs up. Have you got it? Lateral coronary. Again, it is completely obstructed this side and it is partially obstructed this side. Can you see? When left, which coronary is this? This coronary is LCX. Of course, it is LCX. No need to say it is LCX, right? This was LAD. In the first diagram, it was LAD because it was anterior wall. When LCX is obstructed, you can see the same story. So when it is completely obstructed, there is transmural infarct in the lateral wall. See the location also and see transmural है कि subendocardial है. Whether it is transmural or subendocardial, it depends on the obstruction, whether it is complete or partial. In the second scenario, you can see LCX is never partially obstructed alone. Whenever LCX is partially obstructed, other twos are also partially obstructed. All the three coronary, it is a triple vessel disease. All of them are partially obstructed. LCX isolated partial obstruction is not observed yet, not in even a single case. That's why the diagram is like this. And in the second case, you can see it is subendocardial infarct in all the walls. In all the walls, it is subendocardial. Appreciate the transmuralness here in this and in this diagram, and appreciate the subendocardial infarct in these two diagrams. Coming on the third diagram, I guess you already got it. What is there in the third diagram? In the third diagram, the third coronary will be obstructed. The third coronary is the RCA. RCA. It is obstructed completely, and RCA is obstructed partially again here, right? Like this. So you can again see here it is transmural infarct in the posterior wall, and here it will be everywhere like small infarcts, micro infarcts are there. Now appreciate what I mean to say. Depending on the location, depending on the coronary obstructed, the location of the infarct will be. So what is the summary? Let me summarize. When LAD is obstructed, the infarct will be in the anterior wall. When LCX is obstructed, infarct will be in the lateral wall. When RC is obstructed, infarct will be in the posterior wall. When complete obstruction is there, infarct will be transmural. When partial infarction will be there, infarct is subendocardial. I guess I am right. Just a second. Yeah. Yes? Shall I move ahead? Give me a thumbs up. Come on. Right. So this is the best diagram in this context. So the same diagram is described in the theory also. You can see. I am done. Right. Okay, no. Gautam, you are asking subendocardial infarcts are always NSTEMI. Now, this is another classification you are asking about. You know, in ECG, we have 5 ways PQRST. It's PQRST, right? So the 5 waves in the ECG of the heart, we are having this, you may be knowing. So for explaining you this question, you are writing right now, asking right now, I have to explain you the ECG features of the infarct. So in the ECG features of the MI, you will see this ST segment. Can you see this ST segment? It in some infarct it is elevated, in some infarcts it is not elevated. So based on that, this is the classification. The two type of the infarcts is STEMI and NSTEMI. So what is the full form? STEMI is ST segment elevation MI, in which this ST segment is elevated, and NST segment NSTMI is non-ST segment elevation MI. So this has nothing to do with subendocardial and transmural. It is some other classification that I will continue in medicine lectures. I have already taken this lecture, but not in pathology class, but in medicine. But no, this is not the right thing to say. It is not always the thing universal that you have written that subendocardial is always NSTMI. No, it is not true, right? So this is another classification you are talking about. Anyways, let me come on the morphological features of MI. What do you mean by morphological features? Morphology का मतलब क्या होता है? What do you mean by morphology? First tell me morphology. What is the meaning of morphology? Morphology is the diagram, that is H&E stain of MI. But in case of MI, do we do biopsy of heart? Do we do biopsy of heart? No, never. We never do the biopsy of heart in a live patient, of course. We never do the heart biopsy. We never. So why the morphology is important? Morphology is important in postmortem, not in live patient. None of the live patient we do biopsy. We do the diagnosis of MI by some other diagnostic methods. We will do blood markers, cardiac markers. We will do ECG. Most important will be the ECG. We will not do a biopsy for the confirmation of MI. No, never. Right. But the morphology feature is important to understand the post-mortem features of MI. Now, I would like to tell you a story here. Imagine there was a man, there was a man who's dead. Who's dead now? Who is dead? So, what is the cause of the death? In this person, what is the cause of the death? What is the cause of the death? He is dead now. He is dead now. So, there was another person with this person at the time of the death, and he is saying at the time of the death, he was having MI. He was having severe chest pain, and after that, he suddenly collapsed, and he is having MI. But the police is suspecting some foul play in the story. The police is suspecting some foul play is there, and the cause of death can be MI, cannot be MI. The relatives of the family, the patient's family, the dead person family, relatives are saying no, the cause of the death is not MI, it can be something else. So it is a discrepancy case, and it is a medico-legal case. So the dead body is coming to the hospital. This is the dead body coming to the hospital for postmortem. For postmortem, for autopsy. The body is coming for the autopsy. Now, the doctor who is performing the autopsy, either the forensic team doctor or the pathologist, both perform the autopsy. So, the person, the doctor, the medical person, the team who is performing the autopsy. So, it is the responsibility of that team to say what is the cause of death. If the cause of the death is MI, yes or no. Depending on that, the police will investigate that case accordingly. Say yes or no. So in such scenario, the doctor who is performing autopsy will take the heart out of the body, right? We'll take the heart out of the body. We'll cut the heart completely and try to look where is the infarct. So first, the doctor will see the gross of the MI, and from the gross area, we will make a slide and we will see the microscopic of the MI. The first thing to be answered to the police whether MI present or absent in the heart. So it can be present, it can be absent. So we have to look grossly first. Grossly पहले देखना पड़ेगा present है कि absent है. So grossly, how does the infarct look? How they are searched? इतने बड़े heart में, heart is a big organ. So in the big organ heart, how a small 0.1, 0.2 or 0.5 or 1 centimeter infarct is searched in a big heart? What is the technique? Does we do some use some special dyes? Yes, we will use a special stain or special dye to search for the gross finding for the infarct. So in the entire heart, this is the entire heart inside the body. In the dead body I'm talking about, the cadaver, the dead body, we will take the heart out, cut the heart into multiple slices, and we will look for the gross. Where is the infarct? Does the infarct present or absent? The first thing. So I will tell you a technique how to search for the infarct grossly. Heart is a big organ. If you cut the slices of the heart, we will cut the heart like this, into multiple slices, 1 centimeter apart. So there is numerous, more than hundreds of slices are there. In each slice of the heart, more than 100 of slices will be there. In each slice, you will look for the infarct everywhere, especially in the left ventricle wall. The three walls of the left ventricle: anterior wall, posterior wall, medial wall, lateral wall. You will search for the infarct. So there is a special stain used for the searching. I will tell you. Now, just suppose you find the infarct. Just suppose you find the infarct. The next question students ask me, Madam, is it necessary to do microscopy? Infarct is already there. You just answer the police, yes, infarct is present, and they will do the investigation further, whatever. So is it necessary to do the microscopy? Yes, it is necessary. Why? Because grossly, I can only say whether the infarct is present or absent. Just suppose it is present, I cannot tell the age of the infarct. Whether the infarct is 1 day old or 10 day old or 1 year old or 10 year old. I cannot tell that. If the infarct is 1 day old, it can be the cause of the death. If the infarct is 10 year old, it is not the cause of the death right now. Right now, cause of death is something else. Right? So it is important always to tell the age of the infarct. That can be told only on microscopy. On gross appearance, we cannot tell whether the infarct is 1 day old or 10 day old or 10 year old. But on microscopy, I will tell you the specific time infarct is how much old. कितनी देर पहले MI का attack आया है. If I tell the police that infarct is 4 hour old, 4 घंटे पहले infarct हुआ है, or it is 4 day old. So police will correlate the time of the infarct with the time of the death. So if the both timings are matching, we will conclude that the cause of the death is MI. Right? And if I say infarct is say 1 year, 2 year, 5 year old or something like that, and death is not 5 year old, death is right now, no? That's why the body is with us, right? So it is not correlating. So cause of death now is something else. So it's important first on gross to see whether infarct present or absent, and if it is present, what is the age of infarct? For that we have to do the microscopy. So currently I am going to teach you gross and microscopy of MI. That is useful for postmortem only, autopsy specimens only. It is not done in live patient. Everyone give me a thumbs up. Deepak, Sufi, have you got it? Adra, Gautam, awesome. Kishore, shall I move ahead? So I am teaching you gross and microscopy. So I will divide. Okay, let me first discuss gross. Then I will come on the microscopy. So in the most simplest manner, I am going to discuss this now. It is very important. Grossly. As I have told you, this is the heart of the cadaver. Okay, let me take a blank page again. Let me draw a human body who is a dead body, and I want to know the cause of the death. I am the doctor who is performing the autopsy of this dead body of this cadaver. Now, it's my responsibility to take out the heart properly. So this is the heart of this person. I will take out the heart properly in a tray, right? I will take out the heart properly in a tray. So let me take the heart properly. So this is the diagram of the heart out of the body of this dead body. This is the diagram of the heart. So what I will do, I will cut the entire heart into slices. These are the slices. Now, ideal thing says that cut the slice at 1 centimeter apart. Every 1 centimeter, cut a slice, and take all the slices in a tray. You will having numerous slices with you. This is the slice look like. All the slices will be like this only. So in each slice, you will have two cavities. We will look specially in the slices of the ventricular area, not auricular. We have two auricles, two ventricles. No? So ventricular area, we will take the slices. So in each slice, we have right ventricle, we have left ventricle. We know MI more commonly occur in the left ventricular wall. So I will preferentially see where is the MI in the left ventricular wall. I will see the anterior wall, posterior wall, lateral wall, medial wall. We know the sequence. It is most commonly anterior wall. Second most common posterior wall. Rare lateral wall or medial wall. There is no MI. Never MI. So I will use a magnifying glass. You know what is magnifying glass? Magnifying glass you may have seen. So I can use a magnifying glass to see the MI in each slice. So what I will do, I will take one of the slice, use the magnifying glass. I will see all the balls here. In this diagram also you can see this is the right ventricle, this is the left ventricle. I am interested in the walls of the left ventricle. I will see the complete periphery, all the walls, all the four walls. So here I am finding a yellow color spot. This is MI, right? This is MI. So I have to repeat the same procedure in all slices. You will say, ma'am, it is a tedious exercise. You are taking multiple slices. In each slice, you are looking for MI in all the four walls of the left ventricle. And you are having multiple, numerous slices with us. And you are asking to search for a spot, the yellow color or brownish spot, which can be any size. It can be as small as 0.5 centimeter. It can be large 2 centimeter one side. I don't know the size. So we can miss it. It is a possibility that we can miss it. If we miss it, we will give a false negative report. We will, if I miss it, I will write in my report there is no infarct. Infarct is negative, but it is not the reality. Actually, infarct is there and I have missed it. So I will inform the police of false negative report. Right? We cannot do that. So what is the solution? The solution is a dye. The name of the dye, the name of the solution is TTT. What is TTT? Tetraphenyl tetrazolium chloride. TTC. Tetraphenyl tetrachlorium chloride. It is one of the question in AIMS few years back. TTC. Right? What I do, I will take a big bucket, a big jar. So this is a big bucket or big jar. It is a red colored dye. It is a red colored dye. So I will fill it with TTC. TTC. Tetraphenyl tetrachlorium chloride. TTC. I will fill it. And I will take all my slices one by one. I will immerse all my hard slices in this solution. I am drawing only one slice, but I am immersing all the slices. So this is one of my slice. This is right ventricle. This is left ventricle. I will immerse all of them, and I don't know the exact time. For a few minutes, I will keep putting here, and after that, I will take all the slices out and wash them. I will wash them. And again, I will see. And again, I will search for the infarct. Now, what will happen? This is a rule. This is a rule that TTC stain, the viable. Now, in the heart, there are two type of areas. Most of the area is viable. Only the infarcted area is dead area. Only the small infarcted area is the dead area in the slice, and rest of the area is viable. So, viable area take red color. And non-viable dead area do not take red color. It remains yellow only. So a contrast will be given to all slices. You can see the contrast here, the red and yellow appearance. See the contrast here. So all the viable area take the red color, but the dead area do not take the red color. So in this diagram, this is the dead area. This is the dead area because it is not taking the color. It remains yellow. So it is easier to find the dead area of the MI after TTC. Rest of the heart will be red. The portion of the heart which is not taking the dye, which is not red, so it will remain yellow only, because normally heart is yellow now. So it will remain yellow only, and you can see the contrast. Red pe yellow kitna acha dikh raha hai. You can easily pick up. That this area is infarcted area. Give me a thumbs up. Give me a thumbs up. Gross color change is visible after how many hours, ma'am? Gross color change, Adra, I'm coming. It starts from 4 hours. Gross color changes from 4 hours, right? 4 hours after MI, right? So, but it's very difficult to pick sometimes. So that's why we are using this TTC. So we can use this TTC in this diagram also. Can you tell me where is the dead area? I guess this one is the dead area, right? Rest all is the viable area because rest all the area is red. This area is not red, that's why it is yellow, and that's why it is the TTC. Now you should ask me the principle behind it. Why, ma'am, only viable areas taking the dye and not the dead areas taking the dye? What is the reason? What is the principle? I will tell you the principle also. So basically, the non-infarcted area, that is viable area, is taking brick red color, the stain of the dye. And the infarcted area, the dead area, is not taking. It remains unstained as a pale zone. So this is the contrast. Now what is the thing here? How should I tell you? Okay. So again, this is the heart, the 4 chambers of the heart. I am interested in the wall of the left ventricle. These are the cells inside the wall of the left ventricle, right? Just suppose this area is dead area. This area is dead area. So in this dead area, the cells are bursted out. The cells are bursted. They are necrotic. So I'm not drawing the cells. They are already bursted. That is the dead area now. Dead area का मतलब क्या है? Necrotic area. What is the definition of necrosis? Chapter 1 pathology. General pathology chapter 1. What is necrosis? It is the burst of the cell. The difference between apoptosis and necrosis. Apoptosis means cell do not burst, but in necrosis the cell burst. So all the cells are burst. So this area is the dead area, just suppose. So there is an enzyme known as dehydrogenase enzyme present in the cytoplasm of the cell. So the viable area have dehydrogenase enzyme inside them, right? But the dead area, since they are bursted, so the dehydrogenase enzyme is already leaked in the blood. So this dehydrogenase enzyme from this area is already leaked in the blood. So this area do not have dehydrogenase enzyme. This area do not have dehydrogenase enzyme because the cells are already bursted. Now, whenever you are giving TTC, so it is a rule that TTC bind with dehydrogenase enzyme. So where the TTC will bind? TTC will bind in this area because dehydrogenase enzyme is present. TTC will be picked up by these cell, picked up by these cell. But TTC will not be picked up. It will not be picked up by these cells because these cells do not have dehydrogenase. So the principle is dehydrogenase. Give me a thumbs up. Everyone give me a thumbs up. It is an MCQ. Please mind it. So non-impacted area, that is viable area, have dehydrogenase enzyme inside them. That will take the dye. They will look red because dye is picked by those cells. But the impacted area is already bursted. There is no dehydrogenase enzyme. So this is the principle. You got the principle? You got the principle? Okay. Okay, listen now. So in the slice, this is the dead area. In the slice, this is the dead area. In the slice, this is the dead area. So I will make a slide, HNE slide of this area only. I will not make slides of the complete heart. I will make slide 2, 3, 4 slides, jitne bhi slides of this area only, right? I will make slides of this area only for microscopy, HNE slides, right? Hematoxylin and eosin slide. Now, infarct is already present. It is for sure. I am not making slide to see the infarct. It is present. It is visible. Infarct is present, right? Infarct is present. It is present. I am not making slide to sure whether infarct is present or not. No, it is present. I am making slide to know the age of the infarct. What is the age of the infarct? Whether infarct is 1 day old or whether it is 1 year old or 10-year old, I want to know that. The age of the infarct is important to correlate with the timing of the death, right? So in medical legal cases, it is the urge. It is the need of that point, right? So I'm making the slide. Okay. So once I make the slide, I'm dividing into 10 time zones. So first understand the 10 time zones given in the Robbins. Now this is the table from Robbins. Students find this table like, bouncer. They don't understand anything. So most of the students tell me, ma'am, this table is a bouncer table and we don't understand even a single word what is written in it. So I will super simplify this table for you. Listen, first let's divide into 10 zones. What are the 10 zones? So 0 to half hour. I am talking about R. So just after MI or death, I am considering as soon as MI is coming, death is occurring at that point only. So this time zones are after MI. It is not related with death. मुझे नहीं पता death कब हुई भी है कि नहीं हुई है, I don't know, right? I'm not sure about the timing of the death, but I am sure about the timing of the MI. Being a pathologist, I will tell what is the age of the MI. I don't know the timing. It is the duty of the police that correlate the age of the MI with the time of the death. Whether it is coinciding or not coinciding, it is not my job, right? I will tell the age of the MI on my report. I'm a pathologist, and after performing the autopsy, after performing the postmortem, I will see the slide, and depending, I will tell you 10 slides now, 10 different slides. So in my dead body means the dead body on my given to me by the police. So in that particular dead body, from the MI reason, first I will use the TTC dye, and from TTC I will come to know the area which is infarcted. From that infarcted area I will make a slide. So that slide is this one, this one, this one, this one, this one. What is the scene on that slide? Based on the picture, the image of that slide, I will tell the police this is the age of the MI. This is the age of the MI. Now police will correlate the age of the MI and the timing of the death, if it is coinciding or not coinciding. That's it. You got my point. So I'm going to tell you 10 different diagrams now. I'm dividing into 10 time zones. So what are the 10 time zones? The first is 0 to half hour. So MI को 0 to half hour ही हुआ है, right? Half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour means 1 day, right? 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. 14 day मतलब 2 week. So 2 to 8 week, more than 2 week, more than 8 week, that is 2 months, right? So okay, let's divide. Okay, so please tell me once again, what are the 10 time zones? So first is 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. So hour में आपके 4 हो गए, right? 24 hour means 1 day, right? Let's start days. 1 to 3 day, 3 to 7 day, 7 to 10 day, और 10 to 14 day. Day में भी 4 हो गए. 14 day मतलब 2 week, right? 2 week to 8 week, 8 week. 8 week means 2 months and more than 2 months. Now listen, more than 2 months it can be anything. More than 2 months I cannot say. More than 2 months में 2 year भी आ गया, 10 year भी आ गया, 20 year भी आ गया. I cannot say. It is more than 2 months. I will say that only. More than 2 months, I don't know. On pathology, on report, I cannot comment more than 2 months. यानी क्या? It can be 2 year, it can be 10 year, it can be 15 year, it can be anything, right? So I will show you 10 slides now, one by one, showing different scenarios. Everyone give me a thumbs up. Everyone give me a thumbs up. So first learn the 10 time zones. These are the 10 time zones we are dividing, and we are seeing the microscopy of all of them. Microscopy. Adra was asking gross kitne pe dikhta hai. So at 4 hours we see changes in the gross. Changes in the gross comes at 4 hours. Can you see? Before 4 hours, it is none. Grossly, we can't see anything. But at 4 hours onwards, we can see something on the gross. But gross picture is not important. Only one thing is there, that is TTC. Coming on microscopy. So microscopy, this is the summary. I will tell you one by one the 10 diagrams now. Let's start the first point. The first point, everyone here on the screen, everyone. So 0 to half hour, it's normal. You will miss infarct microscopically if it is 0 to half hour. Now practically it's impossible between 0 to half hour, the person is dead. Now imagine a person is dead. Within half hour, you are shifting the body to the hospital also. So after coming to the hospital, if the family wants the postmortem, so police requests have to be generated. So a panchnama is generated. Actually, what is happening, I'm telling you, in the hospital, because we perform autopsies very regularly in our hospital, right? So police, a panchnama will be generated from the police station. So from the police station, a legal panchnama will come to the hospital, to the department that it is a medical legal case and the family or the relatives wants the autopsy. So permission is given by the police in the panchnama that autopsy has to be performed by the doctor. Then the body will be taken in the PM room, right? After that, the doctor who performs the autopsy, the team should be available. Though, so medical legal autopsies are performed by the forensic team and pathologic team both, right? So basically it is the forensic team. So they will perform the autopsy, right? So the team should be available, the doctor should be available. So within half hour, everything is not possible. Actually, it doesn't happen ki death bhi ho gayi, hospital mein should be ho gaya, police is giving the panchnama also, the team is available and the doctor started doing postmortem. They took the heart out and within half hour they make a slide. So it is not practically possible, but if someone does that also, it will be normal. So technically within half hour we can miss it. Within half hour there is no change in the MR. If you take the area of the heart and make a slide, it will look normal. It will look normal on microscopy, but it is false normal. It is false negative. Actually it is the impacted area. So within half hour there is no change microscopically. Please mind this one. Give me a thumbs up. Have you got it? What I mean? Coming half to 4 hour. Yeah, this is possible now. Within 4 hour, you are doing the autopsy. It can be possible in some super VIP cases, right? So within half to 4 hours, autopsy is done. So you will find only waviness. Okay, what do you mean by waviness? See this diagram. Can you see? See the lower half of the diagram. Don't see the upper half. See only lower half. What is the normal diagram of the heart? Can you see in this diagram of the heart, you can see cardiac muscles, cardiac fibers. Let me draw the cardiac fibers. These are the cardiac fibers. These are the cardiac cells. There are three types of muscles in human beings. The skeletal muscle, the smooth muscle, the third are cardiac. These one are the cardiac. In anatomy, in histology, you may have learned it. So this is the cardiac muscles. I can see the long fibers. This is the nucleus of the cells, right? And multiple cells, multiple cells. I can't see the cell membrane. The cell membrane fuses with each other. So we know, right? So synetia or fusion of the cell membrane, it is normal thing. So this, but normally they are straight. Normally they are straight, one behind the other. And I can see the striations. You know, striations are present in cardiac muscles if you have read it. So striations, if you zoom, you can appreciate the striation. So I will say the cardiac muscles are absolutely normal looking. So normal nucleus, normal cytoplasm, normal striation, normal shape, everything is normal. The only abnormality, they are wavy. They are wavy. The only abnormality, they are waviness. So normally they are straight, but now they are wavy. But the structure is normal. So this is the first abnormality, waviness. So waviness is appreciated at half to 4 hour. That is waviness. Everyone give me a thumbs up. Have you got it? What is the meaning of waviness here? So the lower half of the diagram, it is appreciated. The structure is normal. Cytoplasm is normal. Striations can be seen. Nucleus can be seen. The cell membrane can be seen. No problem. So, but instead of straight, they are wavy. So waviness is the first thing that is noticed microscopically. It is half to 4 hour, not 0 to half. 0 to half, it will be normal. Half to 4 hour, the first abnormality is the waviness. Give me a thumbs up. Now, from 4 to 12 hour, if you are performing autopsy after 4 to 12 hour of MI, just suppose MI occurs, for an example, MI occurs 8 a.m. in the morning, 8 a.m. in the morning, and you are performing autopsy at 2 p.m. on the same day, 2 p.m. So how many hours have passed? So I guess 6 hours have passed. 8, 9, 10, 11, 12, 1, 2. Yes, 6 hours. So after 6 hours, you are doing the autopsy. So 6 hours will fall in this zone. So it is between 4 to 12, something between 4 to 12. So for an example, I have quoted this example. So you will get one thing, coagulative necrosis. You will get coagulative necrosis. Now see the upper half of this diagram. See the upper half of this diagram. In the upper half, where are the cardiac cells? I cannot find the cardiac cells. Where are the cardiac cells gone? In the lower half, I can see the striations. Here I can see pink colored bands. These are not cardiac cells. I cannot find nucleus inside them. I cannot find cytoplasm inside them. I can find only shapes are there. No nucleus, no cytoplasm. Instead of cytoplasm, dark pink color is there. So this is actually coagulative necrosis. Only the architecture is maintained, but cytological and nuclear details are lost. So it is those who have attended my general pathology lecture, I have told you the coagulative necrosis definition. So it is the tombstone appearance, the ghost appearance, you know. So it is the outline of the cells are maintained, the inner details are lost. I cannot find striations, I cannot find cytoplasm, I cannot find nucleus, only pink color bands are there. So basically, it is coagulative necrosis. So the first thing after the waviness is the coagulative necrosis. Give me a thumbs up. So till now we are done. क्या क्या पढ़ लिया हमने? We have seen that 0 to half hour it will be normal. Half to 4 hour we have seen the diagram, it is only wavy. 4 to 12 hour we have seen the diagram, it is coagulative necrosis. Give me a thumbs up. Proceed ahead. From 12 to 24 hours. From 12 to 24 hours. Death occurs at 8 a.m. in the morning and you are performing autopsy after 8 p.m. in the evening, the same day. 8 a.m. का 8 p.m. हो गया, right? So morning का evening हो गया. The death occurs in the morning, or not death, I'm sorry. MI occurs in the morning. I don't know death, right? MI occurs in the morning and postmortem is performed. The slide is made after 8 p.m. in the same day in the evening. So it is more than 12 hours. More than 12 hours, I mean that. 12 to 24 hours. 12 to 24 hours. Everyone give me a thumbs up. So along with coagulative necrosis, you will get few. Mind the words few. Few neutrophil. Sparse. Few का मतलब होता है sparse. You will get sparse neutrophils. See again the upper half of the diagram. In the upper half of this diagram, apart from coagulative necrosis, can you notice these cells? All these are neutrophil. If you can zoom, please zoom and see all of them are neutrophils. It is multilobated cells. All of them are multilobated neutrophils. Please appreciate multilobated neutrophils, everyone. Everyone means everyone, right? And they are few. Please appreciate they are few. They are not very much, they are few. So that is along coagulative necrosis तो है ही है. साथ में थोड़े से neutrophil भी आ गए. So if I don't have diagram of only coagulative necrosis, you can imagine. So अगर in this diagram in the upper half see only coagulative necrosis is there, so my answer will be 4 to 12 hours. If along with coagulative necrosis like in this diagram, few neutrophils are also there, it is 12 to 24 hours. So you can imagine the diagram. Give me a thumbs up. Everyone give me a thumbs up. Now moving ahead. Moving ahead. So coming on 1 to 3 days. Coming on the next category, 1 to 3 days. Along with coagulative necrosis, instead of few, there will be abundant of neutrophils. Brisk. See the diagram. The diagram is in front of you. See the diagram. Appreciate the diagram. Everyone, appreciate the diagram. Can you see coagulative necrosis? तो है ही है. Coagulative necrosis, the pink color bands are there. The pink color bands are there. But see the amount of neutrophils here. Abundant neutrophils are there. Compare it with the previous diagram where sparse neutrophils were there. And here there are abundant of neutrophils. Everyone give me a thumbs up. So along with coagulative necrosis, brisk neutrophils are there. So answer is 1 to 3 days. Now you are saying what ma'am is teaching us the complete story. Now I will tell you how many MCQs in the previous year question papers of your exams are from this table. You yourself will will get surprised that this table is super duper important. Right? So don't please avoid it and please understand it carefully. Right? So 1 to 3 day along with coagulative necrosis, abundant of neutrophils are there. Coming 3 to 7 day. 3 to 7 day. Now whenever there is a dead tissue, the macrophage will come to eat the dead tissue. Macrophage love dead tissue and they just eat the dead tissue. So macrophage are coming here to eat the dead tissue. So neutrophil start decreasing. And instead of neutrophil, macrophage start appearing. And macrophage after coming, they will start eating the dead tissue gradually. So see this diagram only. In this diagram, I am marking the macrophages. Listen, I guess this cell, I am marking the mononuclear cell. जो multilobated है, those are neutrophil, but the mononuclear cells are macrophages. I can find these only. You can see anyone else who is a macrophage? I can't see in this diagram. As per my knowledge, all other are neutrophil because all other I can see they are multilobated. Only these much cells are mononuclear. So macrophages are just about to come. So neutrophil gradually decrease and macrophage gradually increase. Why the macrophage are coming? You tell me. They want to eat the dead muscle. So if you notice this diagram, you can see the ends of the dead muscle. The ends of the dead muscle are disappearing because they are eaten up by the macrophages. So these macrophages are starting eating the dead muscles. So that is macrophages. Give me a thumbs up. So macrophage will start appearing. The first time macrophage coming at day 3. The first time neutrophil is coming at 12 hours. So neutrophil first time 12 hours पे आते हैं. Mind it is an MCQ. और macrophage first time 3 day पे आते हैं. Neutrophil half day पे आते हैं. 12 hours means half day. And macrophage third day पे आते हैं. Third to 7 day. Coming further. चलो और आगे बढ़ेंगे. Right. Till now क्या पढ़ लिया? Till now what we have studied? We have studied 0 to half hour is normal. Half to 4 hour is waviness. 4 to 12 hour is coagulatory necrosis. Only coagulatory necrosis. 12 to 24 hours. You can imagine the diagrams. 12 to 24 hours along with coagulatory necrosis, few neutrophils. 1 to 3 day along with coagulatory necrosis, abundant of neutrophils, brisk neutrophils. From 3 to 7 day, neutrophils start decreasing and macrophages start appearing. So from 7 to 10 day. Now it's time to study 7 to 10 day. Kya hoga, right? Now macrophage will eat all the dead muscle. So see the diagram. Macrophages have eaten all the. Can you see the dead muscle? Yes, I can see the dead muscle. ये नीचे नीचे दिख रहा है. So the lower half is showing the dead muscle. The lower half is still present. Some dead muscles are present. The necrotic, coagulated necrotic muscles. But the upper half, all the dead muscle is already eaten by the macrophage. Macrophage have finished eating the upper half, the dead muscles, and gradually they will eat all the dead muscle, right? Now instead, what the dead muscle will disappear. That will be eaten by macrophage. उसकी जगह पे क्या आएगा? So what is replacing the dead muscle? After macrophage eat the dead muscle, it is replaced by fibrosis. It is replaced. Can you see the collagen behind? So all these are collagen fibers. So now who will form the collagen? Collagen कौन बनाता है? Collagen is formed by fibroblast. So now fibroblast will come. The third cells. पहले न्यूट्रोफिल आए, फिर मैक्रोफेज आए. अब मैक्रोफेज डिक्रीज होंगे क्योंकि मैक्रोफेज का काम होने लगा. What is the job of the macrophage? The job of the macrophage is to eat the dead muscle. Most of the dead muscle is already eaten, no? So they will start decreasing, and instead of them, the third cell will come. That is fibroblast. So first neutrophil will come, then they will decrease and macrophage will come. Then macrophage will decrease and fibroblast will come. Fibroblast will start synthesizing the collagen in the background. Can you see collagen is the fibrosis? So these fibroblasts are spindle-shaped cells. All of them are spindle-shaped cells. They will come and they will start forming collagen and fibrosis in the background. Along with that, few blood capillaries will also come. So this tissue is known as granulation tissue. What is known as granulation tissue? What is granulation tissue? Granulation tissue is coming instead of the dead muscle. The lower half is the dead muscle. Gradually it is eaten up and the dead muscle is replaced by the granulation tissue. Dead muscle is disappeared. It is eaten up, wiped up by the macrophage. And instead of it, the background contains the fibrosis formed by the fibroblast cell and granulation tissue start appearing. That is, जब granulation tissue आया मतलब fibroblast आ गया. So fibroblasts start appearing and fibroblasts start making collagen. So collagen is the granulation tissue. Give me a thumbs up. At 10 to 14 days, granulation tissue will become maximum. Now at 7 to 10 days, it just started at the margin and then gradually it will establish and gradually the complete area will have only granulation tissue. All the dead muscle is already eaten up by the macrophage and it is replaced by the granulation tissue. After that, at 2 to 8 weeks, you will find only collagen, nothing else, no cell. अभी तक fibroblasts थे ना? Till now, the first neutrophils were there. Then neutrophils become abundant. Then macrophages are coming. Then macrophages are replaced by fibroblasts. And fibroblasts are making the... Now all the cells will disappear. Nothing. All cells disappear. Acellular collagen. Acellular collagen. See the diagram. This is all acellular collagen. Nothing else. And in the end, scar is there. This is the end result scar. Everyone give me a thumbs up. Can you tell me the 10 diagrams? No, these are all 10 diagrams. Not 10, exactly 4 or 5 diagrams. I told you. I have explained you all 10 findings, right? So these are the 10 diagrams. I have took these diagrams from Hirschman and this is the diagram from Robbins. You can see it out. Robbins with these diagrams are given. You can see the same stages there also. I will explain you in Robbins also if you want. But in Robbins, understanding is a little bit difficult. But if you read this context along with the images, you will find what the author wants to tell us. So in the first diagram, you can see the waviness. Let me appreciate you waviness. Can you appreciate waviness here? This is the first diagram, waviness. Along with waviness, you can see the coagulatory necrosis here. Coagulated necrosis. Along with that, you can find few neutrophils here. Few, not brisk, few. In the second diagram, coagulated necrosis is there. This is all coagulated necrosis. But along with that, abundant, the brisk neutrophils are there. Brisk neutrophils. After that, going in the third diagram, there are few macrophages also यहाँ पे, and gradually they will start eating. So this is granulation tissue, right? In the fourth, you will find only collagen, and this is scar. So the same findings are there. Whatever diagrams you are finding easy, you can do that. Who will help me in the revision? Someone among you? So what is the summary? Look at the summary ones. So the first find, how I used to remember it. What is my way of remembering it? Let me write that. So first I write the 10 time zones. Always, it's my way. You can learn by your own way. So the 10 time zones, what are the 10 time zones? So start with R, 0 to half, R, half to 4, R, 4 to 12, R, 12 to 24, R. 24 hour means 1 day. Now coming on day, 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. तो ये day का भी हो गया. So 4 things are from the hour, 4 from the day. 14 days means 2 week. So 2 to 8 week. So this is from week. And 8 week means 2 month. So more than 2 months is everything same. So 1 week, 1 month. So 4 categories from the hour, 4 from the day, 1 week, 1 month. So learn the numbers. You cannot mismatch that. These are most important. The most crucial thing is to write the 10 findings. So students find this difficult, so I'm making it easy. You got my point? So that is the 10 time frames. The 10 different time frames. Now who will tell me the answers? Sufi, Adra, Kishore, anyone? Anyone can participate. Tell me 0 to half hour. What you will find in the microscopic? Or instead of writing, I will say draw the diagram. Draw 10 diagrams. That will be the best thing you can do in this chapter, right? So draw 10 diagrams. Or instead right now tell me with the finding. I will write it. I will not draw it every time. Tell me, yes, anyone? Can you hear me? Yes, Kishore, absolutely right. It is normal. 0 to half hour, it will be normal. You will miss it. Half to 4 hour, yes, awesome. Half to 4 hour. What is the finding in half to 4 hour? Absolutely right. It is waviness. Waviness. Yes, Adra, absolutely right. And half to 4 hour, it is waviness. So continue it writing. So half to 4 hour, it is waviness. 4 to 12 hour, only coagulative necrosis. 12 to 24 hour, along with coagulative necrosis, few neutrophils. Few neutrophils. So few neutrophils. Neutrophils first time appear at 12 hours. Mind it. 1 to 3 day, along with coagulative necrosis, abundant, that is brisk neutrophils. 3 to 7 day, neutrophils start decreasing. It is already brisk. Now it will start decrease. हर चीज का peak आता है फिर fall आता है. It is also a rule of universe. Whatever is rising has a peak. Nothing can be ever rising in this world. So whatever in this universe is rising, that has a peak, and after peak there is a downfall of all the things in this universe, right? So neutrophils ka peak ho chuka, now the neutrophils will fall. And after that, macrophages will start rising, right? Macrophages will coming, start eating the dead muscle. Whenever macrophage will eat the dead muscle, so granulation tissue will form. Am I right here? So granulation tissue will start forming only at the margin. And at 12 to 14 days, it is well established. The granulation tissue is well established. Everywhere it is granulation tissue only. Now everything is gone, it will become acellular and only collagen will be there. And in the end, scar. In the end, scar. So if you are finding a scar in the end, so it is an old MR. It is more than 2 months and it can be anything. More than 2 months can be 2 year, 5 year, 10 year, 20 year, whatever. I don't know. So it is more than 2 months. So I'm a pathologist. If I'm doing the autopsy of a dead body, so my report will be very specific. In autopsy report, you have to be very peculiar about the words. You cannot write anything. ठीक है? It is a medical legal case. कल को आगे तुम्हें कोई भी sue कर सकता है. So you have to be very peculiar about the wordings, right? So I will write I can see a scar on my slide. So according to me, the impacted area is more than 2 months. I don't know more than 2 months is what, right? So it can be anything. Take the history from the family members. More than 2 months, मतलब कब उसको last time MI का attack आया था? I don't know. It can be a silent attack also. If I am finding waviness, so my answer will be it is half to 4 hour. But between half to 4 hour, exactly kab? I don't know that. I don't know that. So up to my knowledge, whatever is written in this table, that I will report in my words in the report. You got my point? Yes. So that is the thing. So this is the complete table we have filled. We have seen the diagrams also. We have done the revision. We have filled the diagrams. I would like to launch some questions based on that so that you will have an idea how the questions are asked on this topic. Are you ready for the questions? I guess. I want not only 2-3 students who are interacting. I want everyone to participate in the poll. Please, everyone participate. At max you will be wrong. It's okay. Please write your answer in the chat box. Whatever you find it, write your answer in the chat box. This is the question in front of you. Can you see the question? Reversible injury in myocardium occurs up to what time? Reversible means you are missing it. It is reversible. Up to what time? There is no change. Up to what time there is no change? It is reversible and you are missing it. Yes, what is the correct answer here? There is a little bit lag whenever I show the slide and the things come to you. So I can see on the screen a little bit lag. Yes, Kishore, absolutely right. So correct answer here is 30 minutes. So up to half hour, there is no change. That is the injury is reversible. Yes, absolutely right, Kishore, awesome. The answer here is 30 minutes. Everyone agrees? Everyone agrees? So shall I move to the next question? This is the next question. You can see up to 0 to 4 half hour, it is normal. That's my answer is 30 minutes here, right? Coming to the next question. This is the next question. Now it is a typical question. Please read. During the autopsy, I'm performing the autopsy, of course, of a patient who is dead. Of course. So during autopsy of a patient died of suspected MI. We are suspecting MI. We are not sure. The police is suspecting MI. That is the cause they have handed the dead body in the hospital to do the autopsy to confirm whether the cause of death is MI, yes or no. So the heart is stained with a dye. The name of the dye is TTC. The name of the dye is TTC. Tetraphenyl tetrazolium chloride, TTC. What will be the color of viable myocardium? I'm asking the color of viable. Viable. Yes, everyone is right. Adra, Sufi, Kishore, awesome. Very good. Everyone is right. Right. So what is the correct answer? Viable one is the red. Viable one is the red. And what instead of viable, if I ask the non-viable area, what is the color of non-viable area? The non-viable will not take the stain. So it will remain yellow only, but yellow is not given in the option. So go with dark brown. So yellow or brown color, but not red, right? So go with D in that case, right? So viable area is red. Here viable is asked, so that's why the answer is C. You got my point? So what is the principle behind that? The principle behind that is the dehydrogenase enzyme. You know the story, dehydrogenase enzyme, right? So you can see this is the dead area, which is yellow or brown in color, and the complete remaining area is red in color. That is viable area. Because dehydrogenase enzyme is present in these cells and dehydrogenase enzyme is absent in these cells, because in these cells, in this area, the cells are already bursted. So dehydrogenase is leaked in the blood, right? Can I move ahead? Yes. Now this is a difficult question. I am warning you. The question is difficult. So don't rush. Let me read the question. Have a thought. Then tell me what is the correct answer. Right. A 45-year. Now we will take the clues from the question. It is a question few years back from AIMS. Right. 45-year-old male have severe chest pain. Imagine a 45-year-old male is there and severe chest pain. He was admitted to the hospital and the diagnosis was made of acute MI. So he is already a case of acute MI. Right. 4 days. Please mind, it is not 4 hours. It is 4 days. 4 days later he died. He died in the hospital only 4 days later of the MI, of the chest pain which is diagnosed as MI. That is 4 days later after MI, he is dead. So after death only autopsy can be done. Autopsy cannot be done in a live patient, right? So after death, we have performed the autopsy. And on autopsy, we find transmural coagulative necrosis, number 1. And along with the coagulative necrosis, which of the following feature will be there at this point? At day 4. At day 4, I want to ask. Now you tell me the 4 options are in front of you. So I want to ask you the finding at day 4. At day 4 क्या मिलेगा? Fibroblast and collagen मिलेगा? Yes or no? Granulation tissue मिलेगा? Yes or no? Neutrophil मिलेगा? Neutrophil infiltrate along with the coagulative necrosis at day 4, or granulomatous lesion मिलेगा? What you will find at day 4, 4 days later? What you will find at 4 days later? What you will find? Yes? So anyone? So best is to go with C here. Best answer. C is not even correct answer, but in the other. So 4 day. 4 day कहाँ पे है देखने दो मुझे. Where is the 4 day? Yeah, it is fitting now. So 4 days coming in this zone. It is 4 day. 3 to 7 day के बीच में आएगा 4 day. I'm not saying 4 hour. It is 4 day. At 4 day, neutrophil decreases and macrophage increases. So this was the best option if given in options. But in the options, there is no mentioning about the macrophage. But it's okay. At least neutrophil is there. Right? See the other options. What are the other options? The other options are fibroblast and collagen, granulation tissue. So where is fibroblast and collagen? The collagen and fibroblast is here. Granulation tissue is here. So it is not at 4 day. It is beyond 4 day. Right? And granuloma तो होता ही नहीं है ना. Granuloma occurs in tuberculosis, not here, right? So in MI there is no granuloma. So this option is out of the way. So best to go with C. Everyone agrees with me? If everyone agrees with me, give me a thumbs up. Everyone give me a thumbs up. Give me a minute. Let me confirm if I can see your proper chat. I'm not missing anything. You have to give me a minute to open the chat on the mobile also. Although there is a screen in front of me, I can see your chat on the screen also. Yeah, on mobile also it's same. So I guess only these students are interacting. Okay. So yeah, I can see the chat. Anyways, let me move further. This is the next question. Easy one. I guess everyone will be right here. So it is a very easy question, I guess. So earliest histological change in MI. Who will tell me the earliest histological change? The first histological change. First histological change. The 4 options are in front of you. Macrophage infiltration is the option A. Neutrophilic infiltration is option B. Waviness is option C. And coagulative necrosis is option D. Kishore, you are doing rush. Not D. उससे पहले भी कुछ होगा, Kishore. Before coagulative necrosis, something else will happen. So what is the first change I am asking? The first change is waviness. Yes, the first change is waviness, right? Now my next question in the, yeah, here the answer is C. I agree. I want to arrange them in sequence from early to late. Right? Fastest finger first. So it's KBC. Right? Arrange them. From early to late, arrange them in a sequence. So is it ABCD, CBDA, DBCA? What is your options? Write down the sequence. So early to late. So first is already told you. The first is C. What is the second? What is the third? What is the fourth? So you already know the complete story. Arrange them in a sequence and write down your answer. The fastest finger first. Yes, anyone can do that for me? Yes, you know the story. Yes. So सबसे पहले होगा waviness. Yes. So Adra have written CDBA. Kishore also written CDBA. Let me check. Let me check. So first सबसे पहले होगा waviness. Waviness occur at half to 4 hour. Right. After that coagulative necrosis occurs at 4 to 12 hour. This is R. Right. Coagulative necrosis के बाद neutrophil first time occur at 12 to 24 hour. Right. And then macrophage will come at 3 to 7 day. Right. So you can see it is C, D, B, A. Very good. So everyone is right now. But the fastest is the Adra. Yes. So CDB is the correct. So you can imagine the good MCQ will be यही 4 options देके 4 options आपको ऐसे दे दूं मैं A, B, C, D. What is the correct sequence? So you can imagine it is CDBA, it is BCDA, it is ABCD, it is DABC. So students will even get confused, right? So what is the sequence? On the one who is having a thorough knowledge, that can be the right only. Others cannot be right. So that can be a better question than the one which is available here, right? So we can frame the questions like that. Have you got it? Can we move ahead? So correct answer here is C and you all are right. So moving to the next question. This is the next question in front of you. A myocardial infarct showing early granulation tissue at what age? Early granulation tissue. Granulation tissue has started appearing. Just started, not well established. It started appearing. I'm asking about early granulation tissue. Can you tell me at what age? You want to see the table? See the table. Tell me early granulation age कहाँ पर है? Where is early granulation age? Granulation stage. So granulation tissue start forming at the margin at 7 to 10 day. Now look at the option. Does the option contain 7 to 10 day? It will be the best option. So 7 to 10 day कहाँ है? 7 to 10 days, not 1 hour, not 24 hour, not 1 month. So best is to go with C. That is within 1 week is 7 to 10 day we can say. It is not, I agree, it is not the best option. It is not the correct option. But among the 4, it is the best one. I can say that. Right? Give me a thumbs up. Everyone give me a thumbs up. Everyone. Shall I proceed ahead? Jamila, on what topic microbiology you want the session? Write down the topic, not episodes. I take multiple series and I forgot in what episode what I have taken. So write down the topic exactly. What do you want in microbiology? If I'm having the links available, I will share with you and tag me on the Telegram. So shall I move to the next question? This is the next question in front of you. Can you tell me the correct answer? So in myocardial infarction, microscopic picture of what I am asking, microscopic picture of coagulative necrosis with neutrophilic infiltrate is seen at what age? This picture is seen at what age? At what age this picture is seen? Now this question is a tricky question. This question is a tricky question because in the question it is not mentioned whether few neutrophils or whether brisk neutrophils. Whether sparse or brisk not mentioned. So 2 options will be correct. 2 options will be correct. So if you say few, I will go with B. If you say brisk, I will go with C. So whether you will say, why everyone is saying B only? Sufi, Kishore, Adra, can I ask? Why not C? C पे तो brisk होंगे, right? Why not C? You can see here, few neutrophils are coming at this and brisk are coming at this. In the question, it is asked coagulative necrosis plus neutrophil, but it is not mentioned few की brisk. So according to me, both are correct, B and C. But it's your choice. तुम्हें किसके साथ जाना है? I don't know. I don't know. Actually, I don't know the correct answer here. If it is a PG, I go with both B and C. But if you have to mark one answer, so I must say the question is incorrect. The examiner must mention what he want to ask. So if in the question हम थोड़ा सा detail दे दें, I will say neutrophils start appearing. So my answer will become B. And it become maximum, my answer will become C. But from the book I have taken these questions, answer is given as C and the explanation is given that, explanation is written that here maximum are seen, here brisk are seen. So go with C. Although B and C both are correct, right? So Sophie, don't do this mistake in the exam. You are doing this mistakes here, it's okay. But in exam, it is a rule, read all 4 options, right? Examiner are very smart. I'm one of the examiner, that's why I know and I'm smart, right? So examiner intentionally put that option earlier in A and B and the right options below intentionally so that you get tempted to take the incorrect answer, because it is a tendency, human tendency. As soon as you find the answer, you stop reading ahead and you just get tempted from inside. Yeah, ye sahi hai aur chodo aage badho. So this is not the tendency. So being a good student, you should always read four options before taking the correct. Although A is correct, but start reading B, C, D also before taking A. Maybe B, C, D में उससे ज़्यादा better कुछ option हो, right? So in the exam you have to mark the best, and you cannot decide best unless until you don't read all four. So it is a rule that you have to read all four, right? Shall I move ahead? Right. So, okay, this is the next question in front of you. Can you tell me the next question in front of you? It is in front of you. What is the answer? The cells seen after 72 hours. After. Tell me the name of the cells seen after 72 hours. 72 hours मतलब क्या होता है? 3 days. Tell me the cells seen after 3 days in the impacted area. Can you tell me the name of those cells? What are those cells? Neutrophils, lymphocyte, macrophage, or monocyte? Can you tell me? What is it? Yes? So which cells appear after 72 hours? So do you want to see the table? Do you want to see the table? This is the table. I'm asking after 72 hours. 72 hours means 3 days. So 3 days के बाद का टेबल देखना. 3 days के बाद का टेबल देखो. 3 days के पहले का मत देखो. So 3 days के बाद न्यूट्रोफिल तो पहले से ही आ जाते हैं. Neutrophils start decreasing after 3 days. No, neutrophil is not the answer. Macrophage first time appear. Macrophage and fibroblast both occurs after 3 days. But in the option there is only macrophage. अगर ऑप्शन में फाइब्रोब्लास्ट होता तो वो भी सही होता. Fibroblast is the granulation tissue. So macrophage and fibroblast both come after 3 days. Give me a thumbs up. So here in the option only macrophage is there, so I will go with C. But I'm telling you, instead of macrophage, if fibroblast was there, I will go with fibroblast also. Give me a thumbs up. So macrophage and fibroblast both are the correct answer. Here answer is macrophage. Everyone give me a thumbs up, and you all are right, I guess. Shall I move ahead? Shall I move ahead? Kishore, neutrophil is not the answer. Neutrophil is before 3 days, right? After 3 days, I must say, Kishore, that neutrophil to kam hona shuru hota hai. Neutrophil is decreasing. It is not appearing after 3 days. It is decreasing after 3 days. Right? So mind the language, mind the words in the question. They are very important. Right? So pick the correct answer. So the questions are tricky. That's why I'm putting it here. Right? I want you to make mistakes here so that you will not repeat your mistakes in the exam. It's better to do mistakes here. It will fit in your permanent memory कि ये question मैंने गलत किया था और मुझे दोबारा गलत नहीं करना. So cells seen at. I'm saying at, not after. The word here is at. The last question, the word was after. After 72 hours. Here I am saying at 42 hours. 42 hours means 2 days. 2 days पे कौन से सेल होते हैं? Not before, not after. I'm asking at 48 hours. You want to see the table? This is the table. See 48 hours कहाँ पर है? Where is the 48 hours? 48 hours means 2 days. So 2 days is falling in this zone. That is 1 to 3 day के बीच में आएगा 2 day. At 48 hours, only neutrophils are there. Only neutrophils are there. Brisk neutrophils are there. So this time, go with A. Polymorphs means neutrophil. You may be knowing that. Yes, Sophie, absolutely right. So Kishore, this time answer will be neutrophil. You got my point. So this type of tricky questions come in your exam from this table. So this table is a master table. You have to learn this table. There is no way of escape. You have to learn this table. I am done with the morphological features. Let me continue my topic. I'm teaching you MI. Till now, we have learned the definition, etiopathogenesis, the two type of infarcts, subendocardial and transmural. The two type of infarcts we have already learned, right? Location of the infarct. The location of the infarct depending on the wall. Which wall? Depending on the artery. Morphology. In the draws, we have learned the importance of TTC dye. Tetraphenyl tetrasodium dye. In the microscopy, we have seen the 10 time zones and the relevance of each time zone. We have found the age of the infarct depending on the microscopy. It's time to study the clinical features of MI. Shall I start the clinical features? Okay. So starting the clinical features. You may have seen a case of MI. It's very common in your hospitals, in your OPDs, in your cardiac OPDs. You may have seen it. Patient come with typical pain, severe pain. The pain is sudden, all of a sudden, very severe, and it is a pain. It is not discomfort like angina. Differentiated from angina. It is not discomfort. It is actual pain, which is very severe. Patient can't tolerate it. It's not severe. It is very severe, sudden, crushing pain. It is prolonged. It is not like angina 2 to 5 minutes. No, it is prolonged. It is substernal, just below the sternum, or precordial above the heart. One and the same thing. या तो sternum के नीचे या तो heart के ऊपर. In location, which is unrelieved by rest. To differentiate from angina, you have to say this word. It is unrelieved by rest. It is not. If it is angina, it must relieve either by rest or nitroglycerin. It is not relieved by rest, not relieved by nitroglycerin, so it is not angina. It is not angina. And radiating to the arms, neck, and back. So such a pain is MI pain. That is the first clinical symptom, the complaint of the patient. The second is indigestion. Whenever we have pain, we have acidity. We know that, right? So pain, whenever there is a pain, patient also have acidity due to the severe pain. Patient have epigastric pain. That is heartburn, right? The third is apprehension. Apprehension means fear. Patient को लगेगा I am dead now. इतना ज़्यादा pain हो रहा है कि I'm not no longer is going to survive and it's time to end now. So patient have fear of death. At that time, patient is apprehension because of the severe pain. Now see the diagram of the heart. Now what is happening now in this diagram? MI is happening. What do you mean by MI? Actually, what is happening? Uh, one portion of the heart is not working. This portion of the heart is dead. Just suppose, for an example, this portion of the heart is dead. So the cells present in this portion, they are non-functional. Remaining cells are functional. Maybe this portion cell are not functional. So imagine, let me draw few cells here. Okay. I would like to draw few cells. These are the cells, cardiomyocytes, right? यहाँ पे भी पहले cells थे, but they are dead now. In this area, the cells were present initially, but now they are dead. So initially, all the cells were contracting and doing the systole. But now this area is not participating in the contraction because the cells are dead. The remaining cells are contracting, so contraction, systole will become weak. So what is, and depending on the area which is infarcted, maybe big area is infarcted, so most of the cells are not participating in the contraction. So systole will become weaker, weaker, weaker. If you measure the blood pressure here, the blood pressure will fall. The blood pressure will fall, right? Patient will go in shock because less blood in the aorta, all the organs of the body will receive less blood. Especially brain will receive less blood and kidney will receive less blood. Give me a thumbs up. Give me a thumbs up. So patient is going in shock. The blood pressure is falling, right? So patient is going in shock. The blood pressure will fall. The patient have cold extremities. All the organs receive less blood. So hands, the tips, the fingers will also receive less blood. So that is the first organ that is compromised. That is the digits, right? So end organs, if you touch, it is extremely cold. एकदम ठंडे हाथ पैर हो जाएंगे. So extremely cold and calming limbs will be there. Peripheral cyanosis. So all the organs are not receiving blood. So patient will bluish in color. Peripheral cyanosis will. Pulse will be weak. If you palpate the pulse, it is weak. Because the reason is same. Less blood is coming in aorta. And less blood is going in all arteries. So less blood is going in radial artery also. We palpate the pulse here in radial artery. Less blood, weak pulse. Right? Because the systole is weak. Right? Patient can be in tachycardia and bradycardia depending whether it is compensated or decompensated. If it is compensated, heart is trying to compensate by doing tachycardia. And after a stage, heart भी give up कर देगा कि मेरे से नहीं हो रहा and patient will go in bradycardia, right? So that is the features of the shock will be there, right? As I've told you, kidney also receive less blood. All organ will receive less blood. Kidney will go in acute renal failure and oliguria will be there. Patients have oliguria, right? And okay, ये सब तो चीजें because systole is weak. The systole is weak, the blood is not going ahead. So where is the blood going? The blood is going backward. The blood is going backward because it is unable to go forward. So from left ventricle, the blood is going left auricle. The left auricle, the blood is going in pulmonary vein. From pulmonary vein, all the blood is going in lungs and causing edema in the lung. So pulmonary edema leads to dyspnea because of the backflow of the blood and patient can't breathe. Patient have breathing difficulties. Patient have dyspnea, suffocation. So these are the clinical features. So imagine a patient in front of you on stretcher having severe chest pain, having epigastric pain, having fear, apprehension of death, right? The patient is in shock. If you take the pulse, it is weak. If you take the BP, it is low and all organs are receiving less blood. Kidney, patient have oliguria and patient have breathing difficulty. The patient is a typical case of MI. But based on clinical scenario, you cannot start the treatment, right? It is an emergency. So very fast you have to make the diagnosis. There is no time. There is no time. It is the emergency. It is the emergency. You have to be very quick, very fast, and you have to be accurate. You have to make the diagnosis very, very fast and start the treatment immediately if you want to save the patient, right? This is an emergency case, right? How you will make the diagnosis? Only two things. On spot ECG करो. Stretcher पे फटाफट ask the nurse, ask the helper to do the ECG. As soon as just apply the all the electrodes and do the ECG. First thing is to do ECG. Ask the nurse to take a blood sample and send it to the pathology laboratory in that hospital. Call the pathologist. It is an emergency basis. Do cardiac markers and tell me the reports within half an hour, within 15 minutes, whatever. It is an emergency. So do two things: ECG, blood marker. ECG, blood marker. Only two things, right? So ECG and blood marker. Only two things are there to do the diagnosis, which is an emergency. So ECG strip is in front of you. The nurse will perform the ECG and the strip is in your hand. So what you have to see in the ECG? What is the normal ECG? This is the normal ECG. In the normal ECG, you have 5 waves. This is P, Q is a negative wave. This is R. This is S is again negative, and this is T. Right? I took lecture on ECG also. In my last batch, my ECG lectures are available in which I have discussed everything about ECG from normal to all the abnormalities of all 5 waves. If you want, I can share the links also. And this batch also, I am planning to take again ECG live lectures. Anyways, that thing apart, in the ECG, you can see the 5 waves, right? Now, what are the 3 abnormalities that will give you the diagnosis as MI? The diagnosis of MI. There can be 3 things. You have to notice, you have to concentrate on 3 things. First, see the ST segment. If it is elevated, can you see the ST segment here and here? Okay. See ST segment here. Can you see this is ST segment? And see, it is elevated here. So ST segment elevation indicate MI. Number 1. Number 2, T cell inversion. Normally T is a positive wave. Can you see this T wave is a positive wave? But in MI it become negative wave. In MI it can become negative wave. So T wave inversion. And third, see the Q wave here. See the depth of the Q wave here normally and compare it here, the depth of the Q wave. So Q wave become deep. So 3 things are there. ST segment elevation, T wave inversion, deep Q wave. Say it again. ST segment elevation, T wave inversion, and deep Q. Deep Q. These 3 things, one of these 3 things may be there, it indicate MI. Give me, this is a broad. Baki to ECG, it is much detail of MI, right? So that you will study in your final years in medicine. So anyways, that these are the ECG changes. Now, what about the cardiac markers? What you have done from the patient, you have taken a blood sample and sent that blood sample to the laboratory. Actually, what is happening? This is the heart, the 4 chambers of the heart. I'm interested in left ventricle. I'm interested in the cells of the left ventricle. So these are the cells of the left ventricle, right? Now I'm saying the patient is in MR, right? This is the blood vessel of this patient, right? This is the blood sample of this patient. I've taken a blood sample in a test tube. What I want to look in this blood sample? I'm sending it to the laboratory. What this blood will contain in case of MI? So let's do MI. In this diagram, let's do MI. So which color should I select? Okay. So just suppose the group of cells are dead. These groups of cells are dead. 4, 5, yeah, whatever. Then it will be in thousands, right? So whatever amount of cells they are dead here. What do you mean by death? What do you mean by cell death? What do you mean by cell death? Here, necrosis is taking place. What do you mean by necrosis? The cell will burst. When the cell will burst, the cytoplasm of the cell contain many enzymes. There are 5 important enzymes that will be leaked in the blood. So 5 enzymes that will be leaked in the blood. We are collecting the blood in a test tube and looking for these 5 enzyme concentration. If these 5 enzymes are raised in the blood, the patient have MI. Have you got it? कि blood में हम MI कैसे check करते हैं? Students who don't have overview कि blood में क्या दिखेगा? MI के case में okay, ECG समझ में आता है. What you have to see in the blood? You have to see the cardiac markers. Okay, what are cardiac markers? Cardiac markers are 5 enzymes which are raised in case of MI. Why they are raised in case of MI? Because in MI, the cells burst. The cells of the heart are burst. So there are 5 enzymes which are present in the cytoplasm of the cells. While bursting, they will leak in the blood. Give me a thumbs up. Come on. Right? So they will burst and the markers will come in the blood. So actually, what are cardiac markers? First define them. The cardiac markers are present in blood. They are leaked in the blood. Why they are leaked in blood? Because they are present as intracellular enzymes in the cardiac cell and they leak out of the dead cell when the necrotic cell bursts. Now give me a thumbs up if you got the overview. Name the enzymes. So the same diagram from the Robbins you can appreciate. Here you can see this is the wall of the left ventricle. You can see these are the cells. When they are bursting, you can see these are the enzymes and they are leaking in the blood. So you are taking the blood sample in a test tube and looking for the 5 enzymes. Name of the enzyme. First name them. Then we will see the relevance of each of them. The 5 enzymes which are leaked into the blood are myoglobin, CPKMB, troponin T or troponin I, SGOT also known as AST, and LDH, the dehydrogenase, which was the principle of TDC diet, right? So these are the 5 enzymes, right? One by one we will see. Now as soon as the MI start and the cells start bursting, the first marker which come in the blood, the first enzyme which come in the blood is myoglobin. So myoglobin का relevance यही है, it is the earliest marker which is detected in the blood. Earliest. So it is the earliest. It is coming just after 2 hours of MI. As soon as the patient have started the attack of MI, within 2 hours myoglobin will be leaked in the blood. So it is the earliest marker. So you will say now it is a good thing, but I will say it is non-specific. The bad thing is that it is non-specific. So all the muscles, there are 3 types of muscles: cardiac muscle, smooth muscle, and skeletal muscle. If any muscle is bursting, myoglobin will be in the blood. So if you find the myoglobin in the blood, it is not only cardiac cells are bursting. It may be you have done too much of exercise today, you have done jogging, swimming, running, and your skeletal muscles have bursted. It can also lead to myoglobin increase in the blood, or some smooth muscle is bursting. So that can also lead to myoglobin. So it is non-specific. I can say based on the symptom along with myoglobin raised, patient is having chest pain, shock, everything, and so I can correlate. But only myoglobin raised in the blood do not give the diagnosis of MI. You got my point? So it is earliest. I agree, but it is non-specific because many other things also leak myoglobin in the blood apart from heart cells. Everyone give me a thumbs up. So it is earliest but non-specific. Right. Coming on the second enzyme. The second one, give me a thumbs up. Come on, you got it. So we definitely, I will tell you the ECG links in the group, but tag me. I will forget it, right? So please tag me. Once or twice tag me. Give me a reminder. Then definitely I will tell you, right? Otherwise I will forget it. CPK-MB. The next enzyme is CPK-MB. So what is CPK-MB? What is the importance of उससे पहले एक दूसरा पढ़ते हैं troponin T और troponin I. The two types of troponin T and I. They come after 48 hours. I'm sorry. They come after 4 hours. They come in the blood after 4 hours. So they are not earliest, but they are specific and sensitive. So if you find troponin T or troponin I in the blood, it is definitive the patient have MI because no other cell in human body from head to toe have this enzyme. Only heart cell have this enzyme in the cytoplasm. If these enzymes are present in blood, means some of the heart cells are already bursted. Means MI is certain. MI is confirmed diagnosis. So troponin T and I are most sensitive and specific marker. So earliest is myoglobin, but most sensitive and specific is troponin T. Right? So it comes after 4 hours, but it disappears after 7 to 10 days. It disappears after 7 to 10 days. Till 7 to 10 days, it will remain in the blood. It will remain in the blood for a long time, 7 to 10 days, right? Now, you know, whenever MI comes, the doctor says that within the next 48 hours or 72 hours are risky because it is a tendency to re-attack. Re-attacks are very common. So whenever one attack is coming, maybe coronary is still obstructed. What is the reason for the attack? What's the reason for the MI? One of the coronaries is obstructed. Maybe it is still obstructed. Some more emboli, thrombus are there. And chances of re-attack, re-infection are common within the first 48 and 72 hours. So the first 48 and 72 hours are crucial. You may have heard that. So patient is kept in vigilance in the ICU, right? So reinfections are common within first few hours. So if reinfection is coming and troponin T once raised in the first attack, the suppose first attack is there. So troponin once raised, I know it is specific, but it will remain raised for the next 10 days. And if reinfection is coming next 48 or 72 hours, it will remain raised. You cannot differentiate whether this troponin is coming from the first attack or second attack. So it is not a marker for reinfection. Troponin T is specific. I agree. It is the best marker. It is sensitive. It is specific. But it is not a marker of choice for reinfection. Because once raised in blood, it will remain raised for the 10 days. लेकिन 10 days के बीच में दूसरे और इन्फाक्ट आ गए तो उसका मार्कर क्या है? तो उसके लिए CPK-MB. CPK-MB. So CPK-MB it also rises after 4 hours, but again decline after 2 days. 48 hours के बीच में वापस decline हो जाएगा. So if you finding like this, CPK is rising, falling, and again rising. So it is reinfarction. You got my point? Is so marker for reinfarction is CPK-MB. So till now we have read 3. Myoglobin is earliest, that is the best thing, but non-specific. Troponin T is the specific sensitive, but not a marker for reinfarction. The marker for reinfarction is CPK-MB. Everyone give me a thumbs up. Till now is it okay? The next are SGOT, SGPT, and LDH. Both of them are non-specific. Yeah, LDH की खास बात. It is the last marker which become normal. It comes in the blood within 24 hours, but it remains in the blood for after 10 days also. So it is the longest marker which remain in blood after the attack of MI. So can you enumerate the 5 markers and their relevance? What are the 5 markers, cardiac markers? The first I would like to write myoglobin. Then I would like to write troponin, trop T, trop I. Troponin T, troponin I. The third I would like to write CPK. It is MB variant of CPK. CPK के 3 variant होते हैं, MB वाला, right? Then the fourth one is the LDH, and the last one is SGOT, SGPT. SGOT or SGOT, right? So tell me the relevance of each of them. Myoglobin, the main point is that it is the earliest to come in the blood, right? Within 2 hours, it will come in the blood after MI. Trop T, trop I, it is most sensitive and specific, right? Myoglobin is earliest, but it is non-specific, right? But trop T is just most sensitive, most specific, but remain in the blood for 10 days. So it is not a marker of choice for reinfarction. Marker of choice for reinfarction is CPK-MB because it becomes normal within 48 hours. And after 48 hours or within, it is rising again. So it is reinfarction, right? LDH, it is the longest marker which remain in the blood. It remains in the blood even after 10 days of MI. And as you know, is an important point is there. Everyone give me a thumbs up. So these are the 5 markers. You can see CPK-MB, as I have told you, it is of 3 types. CPK. CPK-MM, it is present in the cytoplasm of the skeletal muscle. BB, it is present in the cytoplasm of the brain. And MB, present in the cytoplasm of the cardiac muscle. So don't see only CK. See CPK का MB वाला variant in the blood. That is important, right? So MB में भी दो होते हैं, MB1, MB2, right? So that is the specific, right? So that is about the CPK. After that, we have seen LDH. LDH remains in the blood for about 14 days. So it is the longest marker which is remaining in the blood. Troponin. Troponins are of 2 types, TROP-T, TROP-I. These both are most sensitive and specific marker for MI. After that, myoglobin, it is the first marker but lacks sensitivity, lacks specificity, right? So that is myoglobin. And that's all about it. You can see the graph. You can see the timings when they are coming, becoming peak and going back. So you can see earliest to come in this graph. I can see earliest is coming myoglobin and last to remain is LDH. ये दोनों तो दिख रहे हैं. The first to come is myoglobin and longest remaining in the blood is LDH and remaining are in between. Give me a thumbs up. Everyone give me a thumbs up. So coming on the complications of MI. In the complications of the MI, arrhythmia is the most common complication and that is the most common cause of death in MI. So arrhythmias are there, heart failure can be there, shock can be there, sometimes rupture can be there. You can see a rupture here. Can you see a rupture here? Cardiac aneurysms can be there, pericarditis can be there, post-MI Dressler syndrome. So I'm not going in the details. I'm done with the complications and salvage therapy that will be taught you in medicine lectures, right? So I would like to learn some polls from here onwards, right? Some polls are there. So this is the first question in front of you. Can you tell me the first marker to be raised in MI? First marker to be raised in MI. The 4 options are in front of you. Let me see your chat. Give me a minute to open the link again on YouTube to see your chat. Okay. I can see, I guess. You sure? Absolutely right. Yes. So what is the correct answer? The correct answer is myoglobin. So first enzyme to be raised in MI is myoglobin. You got it? Give me a thumbs up. So the correct answer is myoglobin. You can see within 2 hours it is coming in the blood. Yes, awesome. You are also right. So tell me the answer. Post MI, day 10, which marker is still present in blood? So I want to ask the longest to remain in blood. In the first question, I asked the earliest. In this, I'm asking opposite of earliest. I'm asking the longest to remain in the blood. So after 10 days also, till 14 days, which one is remaining? Which one is remaining? Which one will remain? Yes, Kishore. Absolutely right. The answer is LDH. So it is the longest which will remain in the blood. Yes, absolutely right. Yes, Subhanshu. You are also right. Very good. So correct answer here is E. Right. Coming to the next question. Yes, Raghav Sharma. Very good. So this is the next question in front of you. It is a tricky question. I want to see who will tell me the correct answer. In stable angina, the question is from angina, not MI. In stable angina, you tell me the answer. Which enzyme is elevated? CPK, MB, troponin T, myoglobin, or all cardiac enzymes will remain unchanged? In stable angina, which enzyme will raised? This one will elevate it, this one will elevate it, this one will elevate it, or no one will elevate it? I want to ask you. The question is from angina. Adra, absolutely right. Yes. So angina is differentiated from MI based on cardiac markers. In MI, as I've told you, the cells are bursting. Necrosis take place. The cells are bursting. That's why the 5 enzymes are leaking in the blood. But in angina, there is no bursting. Necrosis do not take place because in angina, the ischemia is transient. It is not persistent. So necrosis do not take place in angina. That's why in blood, all the enzymes are normal. No Shubhanshu. TROP-T is the best marker for MI. In angina, all of them are normal. Yes, Raghav, all of them are normal. All of them are normal. You got my point? So that is the difference between angina and MI. In angina, there is no necrosis. So I am done with the topic. I am done with the topic. I taught you today, I taught you complete ischemic heart disease. All about angina, whatever possible questions, angina, the various types of angina, all about MI. We have studied everything, the gross, the morphology, the clinical features, the complications, the diagnosis, the types, the location, everything. Give me a thumbs up. Now I can challenge, you can practice any question on ischemic heart disease or coronary artery disease, one and the same thing, and you will be right in your questions. If you still find any trouble, you can tag me on the Telegram. I am available on the Telegram. On Telegram, there is a Telegram group of Unacademy. The name of that group is Let's Crack NEET PG. First join that group. It's a group of Unacademy, right? Now go in the members of that group. In the members of that group, I am available. My Telegram ID is MedLive by Dr. Priyanka. Search me by this name, MedLive by Dr. Priyanka. You will find me by this name in the members, and you can text me your doubts, your problems, anything related to studies, any your queries, right? So if possible, I will guide you there. So thank you very much for being with me. I'm having the next lecture maybe after 15-20 minutes. I would like to take rest, a break for 15-20 minutes, and after that I will continue my episode 2, the next episode of cardiovascular system, that is endocarditis. I'm going to teach you 4 types of endocarditis in the next lecture. So don't dare to miss that lecture. So it's 11, I guess, right now. And maybe at 11:15 or 11:20, right now, I will continue my next episode. So on this YouTube channel only where you are available right now. That is Unacademy Live. I guess it's Unacademy Live NEET PG, right? On the same YouTube channel, you can continue my lecture. Before leaving this lecture, don't forget to click on the like button and share the link with your friends, colleagues, everyone. And don't forget to subscribe our YouTube channel. And there are few announcements for you. I want everyone to come for the next lecture, right? Just after 15 minutes on the same YouTube channel. The name of the lecture is Endocarditis. Join the link for Endocarditis. There are few announcements for you guys by the team. These are the new batches which are started on Unacademy for NEET PG 2023, and there is a repeaters batch also. You can take the advantage and lectures of this batch once you take the subscription. Now iconic price are going to rise soon, so if you want to take subscription, take it soon. Within the next few days, the price hike will be there. It is for sure. So on Unacademy, there are few types of subscription. In Plus subscription, you will get only Unacademy. In Iconic, along with Unacademy, you will get Prep Ladder also. In Light subscription, you will get only test series. In Prof 1, you will get Anatomy, Biochemistry, Physiology classes. In UPSC subscription, you will get UPSC preparation. So whatever subscription, the various plans are available in front of you along with price and duration. You select the best plan for you. Whatever is your best one. Longer plan, cheaper it is. But it's your choice, whatever to take it. Whatever plan you are planning to purchase, apply my code before payment. My code is my surname, Sachdev. It's SACHDEV, Sachdev 10, without space 10. It's code. I am Dr. Priyanka Sachdev. So please apply this code before payment and you will get straightforward 10% discount on all these prices. Thank you for being with me. Join me back for the next lecture. Bye bye. Study hard. All the best. I'm ending this lecture.